Good afternoon, everyone. I am Dr. Rasik Shah, Senior Pediatric Surgeon associated with SRCC Children's Hospital managed by Narayana Health. So we started this masterclass in January 2019 and we are completing 7 years next month. Initially it was physical, now it is online. And I thank you all for your participation, which is giving us encouragement. As all of you know, SRCC Children's Hospital has all kind of facilities under one roof, which includes pediatric cardiac surgery, neurosurgery, bone marrow transplant, solid organ transplant, laparoscopy surgery, ENT, and everything, whatever you want, everything under one roof. We have very good PICU, NICU, pediatric anesthetists. And for doing all this work, we need a very good radiology department as well. So our radiology department is equipped with MRI, which is 3 Tesla, as well as if we need to give anesthesia, which is required in many of our children who needs MRI. So all these facilities are there. There is a very good IITV or fluoroscopy, sonography machine, whatever we need, everything is state of art. But only equipment will not give you the results which you want. So our pediatric radiologist team, which includes Dr. Hiren, Panwala, Sonal, Garg, and fellow Jithin, and there are many other who are visiting interventional radiologists. This entire team gives whatever best we want. And today we will be learning from this galaxy of speakers about pediatric radiology, which includes not only plain radiography, but even MRI, CT, sonography, everything they are going to tell. And most important or very interesting part will be at the end, which will be interactive session with which will be multidisciplinary. And I am sure all of us are going to learn from them. And I request Dr. Hiren Panwala to take over and start with our today's masterclass on pediatric radiology. Hiren is with us for last 4 years now? 5 years? From? More than 6 years. More than 6 years. The time flies, even I can't recollect. He is here for since 6 years, but he gave us the stability in the radiology department, and since then it is growing. He had done pediatric radiology from CMC Vellore, and he will be starting with the session. Hiren, all yours. Yeah, mic yours. Please.
Thank you, sir, for the kind introduction. Just give me one. Yeah, can everyone see the slides? So everybody is able to hear me, and can you see the slide? If yes, just put in a chat box so that I can start. Will be clear? Yes, somebody has mentioned yes. Yes. Okay, so so just brief slide about myself. I'm Dr. Hiren Panwala. I'm right now working at NHSRC Children's Hospital as a clinical lead and pediatric radiologist. I've done my fellowship at CMC Bangalore and did some short-term observership at Great Ormond Street Hospital, UK. I am also an EC member of ISPR Society, that is Indian Society of Pediatric Radiology, since my passion is there in the pediatric radiology field. And have been an author of IRA textbooks in various fields of pediatric, including cardiac imaging and neuroradiology. So today we are going to discuss about when it all begins. We'll start with the introductory slides to the pediatric radiology, and then finally we'll try to see how to interpret the pediatric chest X-ray. So the first of all, the question comes to our mind that what is pediatric radiology? So pediatric radiology is a subspecialty of radiology which is focused on imaging and providing the image guided care for the infants, children, and adolescents. And as this sentence says, or this quote says, that pediatric radiology says what children cannot say. So it's very paramount importance, because sometimes children cannot express themselves that what problem they are having. So in that kind of thing, being pediatric radiology, we can see what is happening inside the body, and we can accurately tell the problem so that the treatment can be given on time. So the why other question that comes to our mind, that why pediatric radiology matters. The thing is that children are not small adults that we have been taught from long ages. That is particularly absolutely true about that finding, because there are certain diseases which we see in children or adolescents that is not at all seen in the adult age group. And amongst children also, if you subdivide the age group into preterm, term, infants and children, they also have some sort of diversification of the diseases which can come into some certain population or certain age group. So that's how the training or the pediatric radiology branch is very important, so that we can give justice to the problem the child is having. It's very important that the pediatric population has got unique anatomy or variant anatomy on it when we do the X-rays, when we do the USG or any cross-sectional imaging as CT or MRI. It has different appearance, so that also have to be aware about. And for this all reading, it requires specialized expertise. So that really differentiate what is normal at this age group versus the abnormal things. So that's why the pediatric radiology matters. The other important and the governing area is the radiation safety area. Especially the children, they are radiation sensitive crowd, so that we should be very cautious when we are like prescribing any CT scan or X-ray, that it is really required or not. And if we are doing the CT scan or X-ray, it should be based on the LRA principle, that is the as low as reasonably achieved principle. And fortunately, we are in that tertiary care pediatric hospital and with this latest machinery in which we have got facilities and some softwares and the protocols where we are able to cut down the radiation and we are able to give radiation to the particular area where we are going to image. So that reduces the radiation to the other part of the body and ultimately it gives result also without harming the child by giving unnecessary excessive radiation. In the radiology department, we always encourage if the problem can be solved or if the problem can be detected on the USC or MRI, we always try to prefer USC and MRI over the CT scan or X-ray. But there are certain scenarios then we have to go ahead with the CT scan. That part we can do with the LRA principle. The other thing that we should be aware about, there is some sort of alliance of radiation safety in pediatric imaging, that is an international wing for the Image Gently project. Our hospital also has been part of that Image Gently project, in which we have taken an oath that we will utilize those protocols when we are giving radiation in X-ray or CT scan, which are internationally curated according to that age group and that particular weight or that kind of variation, so that we are not giving excessive radiation. So just to be aware about that, there is some sort of a group which works on this radiation safety in pediatric imaging. When the child goes for CT scan, we also make sure that the rest of the body part doesn't get unnecessary radiation, so that we give this kind of radiation shielding device. This is the lead apron. And as you can see, that is the mother just trying to calm down the child who is going for the CT scan. And the mother also has been given the radiation protection. She is wearing the lead apron and she also having thyroid caps just to protect the important vital structures of the body. So in this example, we just wanted to image the chest part. That's why you can see that the rest of the abdomen and the lower limbs, they are covered with the lead shield, which is kind of radiation protection. The other important thing when we are doing imaging, it's very important to have child-friendly imaging environment. That helps us because it reduces the anxiety and it enhances the cooperation and improves the image quality, which is very beneficial when we are doing the imaging. So in our hospital, we have this kind of child-friendly environment in which we got a section in which the kid-friendly books are there, in which when the children are waiting, they can go through and they can read those kind of books so that the anxiety and apprehension is less. They have got some toys to play just to ease the situation. We have got this kind of some unique way to counsel them that if the scan is done properly without any sedation and without any motion, we try to pet them by giving this kind of children-friendly stickers in our hospital so that the child also feel good after the procedure has been done. Just to show that the pediatric population, they will have some sort of organ-specific diameters, which is based on the age of the child. So we follow those international guidelines to give the report so that, for example, 5 centimeter size liver maybe normal for the neonatal age group, but beyond that, it should be increasing size. So that kind of age-wise cutoff size we should follow when we are following the pediatric radiology. That's our department, just trying to show our staff who are also very important part of the pediatric radiology because they also need to know the proper technique with LRA principle and they have to be very patient because to image the child is very difficult, especially they are also already afraid and to make them calm and ease out that tension is very important. It's a very important and precise skill that not all can have. So over the time, our technicians have learned that skill that now we are able to do many of the scan without sedation after appropriate counseling of the child and making them calm. That's the MRI room, which shows that child-friendly environment in the surrounding walls. And so the other important thing that when we are talking about the pediatric imaging, we do require sedation for various CT scan as well as MRI and image guided procedures. And that's our excellent anesthesia team who gives us support 24 hours. And fortunately, they are able to handle all the complex kind of airway malformation or difficult intubation with and ease, so that we don't have to worry about sedation part. We just have to tell them that this child needs sedation and they will take care subsequently. So it's very important to have a dedicated pediatric trained anesthesia team when you are doing pediatric imaging. So that also gives an extra advantage, and we are fortunate that we have that team. It's just a console showing us the CT scan and the operating area. One more thing that just wanted to highlight that we also have this kind of stimulatory MRI tunnel kind of toy in which we can explain the child that what is going to happen in a few minutes before the scan, so that the child is ready that they can go inside this tunnel kind of stimulatory toy and they can feel what will actually happen when they are going to the MRI area. So that apprehension is less and we can do the scan without sedation. So this kind of small techniques that really helps when we are doing the pediatric imaging. Then the question comes to our mind that how does pediatric radiology aid treatment? So especially trained pediatric radiologists can guide surgery and they can do this kind of image guided intervention. That's our radiology fellow, Dr. Jithin, who is going to speak on subsequent topic. He's performing an procedure in a child who is sedated, and this kind of we follow this aseptic precaution, and that was some sort of USG guided some soft tissue lesion in the back of the thorax that he's trying to take biopsy from that area. The other last topic, that how does a pediatric radiology support team care? So pediatric radiologists, they work closely with the pediatricians, surgeons, neurologists, and oncologists so that we can give holistic management. This is an example of a multidisciplinary meeting that we regularly we do on every Monday on epilepsy meetings, which requires comprehensive team of neurologists, neurosurgeon, the pediatric radiologist, as well as the neuropsychologist, to give that comprehensive treatment. And this kind of all kind of support we have in our hospital. So we are fortunate enough to do this kind of high-end work with this kind of dedicated team. We also have got multi-specialty teams of various subspecialty. That's later on we are going to go through. So without wasting much time, just wanted to highlight that we have got CR and DR radiography facility available. We also do fluoroscopy, which is a common procedure in the pediatric population. We are also regularly doing 4D ultrasound with the Doppler, which is including the OPS and Riley scans. And we have got high-end 120 size CT and 3 Tesla MRI, which has dedicated pediatric protocols and excellent backup services. We are doing dedicated cardiac imaging also in CT and MRI. Besides that, all high-end advanced imaging we are able to do on our machines. So these are the highlights of our department that you will find. It's a child-friendly atmosphere, and we follow the low-dose radiation imaging. We have dedicated specialized radiologists as well as anesthesists, and state-of-the-art CT MRI machine, and now we are catering round-the-clock service. So that is regarding the pediatric radiology. Now I'll be taking you through the pediatric chest radiograph, how to read. So I hope everybody can see my first slide. This is the basics and approach to pediatric chest section. Everybody can see, just put in a chat box so that I can, it's seen, right? But my arrow cursor is not seen. Yeah. Yeah, so just starting with the pediatric chest X-ray, these are two radiographs that has been given to you. So anybody can identify any abnormality in either of these radiograph, anything unusual. Just forget about this vascular line for the sake of the time. But anybody can point out any other mistake or any other variation that we are seeing here. This is just eye-opening slides before I start talking about the pediatric chest X-ray. Anybody wants to comment in a chat box? Uh, just waiting for 10 seconds if anybody can answer, or I can answer myself. So just to start with that, whenever we are looking at the pediatric radiograph, you should see besides lungs, all the part which has been covered in the radiograph, which includes the upper abdomen, which includes the bilateral proximal humerus and the bones. So if you carefully see here that usually the stomach is lying on the left side of the upper abdomen. So when you see this kind of large gastric shadow, which is seen underneath the right heavy diaphragm, that means that the anatomy is altered, and that is the left cardiac apex, which is that indicates it's a levocardia with stomach on the right side. So, and here is the cardiac apex pointing towards the left side, and the stomach is also on the left side. So this is called situs solidus configuration, and this is not following the same orientation. So this is called heterotaxy. So the point is that when you are aware about those kind of if you are able to pick up this kind of small finding, then you can guide your the clinicians and pediatrician to go what to do next step, because many of time this heterotaxy syndrome can have associated congenital heart disease, so that echo can be done subsequently and further workup can be done. So the take-home message from first take-home message is that how you look at the X-ray. So don't see it as a tunnel view. You should have always a broad panoramic view that is shown here, right? So these are the example of that situs solidus in which the cardiac apex will be on the left side and the stomach shadow also will be on the left side. And in inversus, it will be opposite. You will see the extrocardia in which the cardiac apex will be seen on the right side and the stomach shadow also will be seen on the right side. So that is the situs inversus, and this is a case of heterotaxy in which you will have reverse orientation or altered orientation of the cardiac structures as well as the stomach. So when you are reading a pediatric chest radiograph, these are the things which comes to our mind. And the first of all, you have to rule out that am I dealing with the thymus or is there a mass? And you should be aware about the potential mimicals and technique related artifacts before labeling anything as abnormal. And you should be able to find out any obesity which may be underlying infection. And if you see there is asymmetry of lung, then which side is abnormal. And you should be able to identify the pleural effusion or empyema or pneumothorax on the pediatric radiograph. So starting with this is just a basic slide that the structures or the soft tissues which has got least density, for example, air, fat, they have least density. So the maximum X-ray will be passing through those areas, and that areas will be seen on X-ray as a black thing or in gradation like a grayish thing on this kind of arrow as it's shown. And when the structure or soft tissue has most dense tissue, for example, bones or metal, they will have absorption of most of the X-rays. So that thing will be seen on the final X-ray output as a white opacity. So that basically you should be aware about. And as I've already told before that children are not adults, they have different problems and different diseases which are not common in adulthood. So we should be aware about those things. And before reading any chest radiograph, you should be able to identify the normal structures. Just for a brief recap of normal anatomy, you should either start from central to periphery or periphery to center. You can choose either of the way. And here we are starting with the airway. So that is the trachea in the midline. And this is the right main mucus, and that is the left main mucus. Followed by that is the right paracardiac shadow, which is called by the SVC. This is the azygous vein. That is just above the right main mucus. That is the right cardiac border, which is formed by the right atrium. This is the shadow which is called by the aortic knuckle, where the arch of aorta becomes the descending aorta. That is the shadow caused by the left pulmonary artery hilum. And this left cardiac border is formed by the left ventricle. Just for the sake of those who want to correlate, you can see the schematic diagram on the right side just for the correlation. And in the lungs, you will see that in the central two-third area is kind of descending and ascending vessels, which are the hilar vessels, which are branching into the upper and lower lobes. So they will cause this kind of tubular shadows. and that is the dome of the diaphragm, which has this kind of gentle concavity. The cardiophrenic angle, this is the cardiophrenic angle, that is the costophrenic angle. So the cardiophrenic angle is slightly higher up as compared to the costophrenic angle, and this kind of gentle concavity is normal. So after going through all the structure, you should also look at the hidden areas of the X-ray, which are the retroclavicular areas, retrocardiac areas, the upper abdomen, and the visualized bones in the X-ray. For example, proximal humeri on either side, because sometimes focal lesions or any diffuse metabolic disease you may identify by looking carefully at the bones. This is the lateral radiograph, in which you can see that the central circle area is the hilum, and you are seeing this kind of two tubular air-filled structures. So the anterior is the trachea and posterior is esophagus. And here is the hard shadow in the mediastinum. This is the spine and the lung shadow superimposed on that spine. And the dictum is that when you go from top to bottom in lateral radiograph, the lung density should reduce. That means it becomes more black as we go lower down. That's the normal finding, because in the upper part of the thoracic spine, there will be superimposition of the axilla and shoulder. So that will cause this kind of opacity in the upper part. But lower part, it should not be any opacity. It should be black thick. So that's a normal anatomy. This is the sternum, and that is the retrosternal space. So it's very important to look at those areas to look up any retrosternal connection. The other thing that how to measure the cardiothoracic ratio. So we can take these lines. So one line should be from the midline of the spine, which is intersecting this posterior spinous process. From that, you can take one transverse diameter maximum, which is touching the right cardiac wall. Similarly, one transverse diameter, which is touching the left cardiac wall. Then you should take a transverse thoracic diameter, which is taken at the level of 9th intercostal rib inner margin. And you can sum the A plus B. That should be divided by the C, that is the transverse thoracic diameter. So this ratio gives us the cardiothoracic ratio. So in adult, this cutoff value is 50%, but in children it is more than 60%, which is labeled as abnormality. Just to show you that when you have some sort of overexposed film, it will show this kind of increased vessels in the periphery of the lung, or some sort of increased haziness, which can give rise to mimic like some sort of viral infection. So it is very important to use proper KB and MS. But nowadays, with the help of the DR system, in which you can play around on your monitor and you can adjust the contrast, which is suitable and normal. So this kind of exposure-related artifacts nowadays are very less seen. The other thing that you should be aware about when you're taking radiograph, there should not be any external objects lying on the body that is being imaged. For example, here is one adolescent girl who had a long hair braid, and the technician forgot to wrap up the hair braid outside the lung view. So that's why they got this kind of abnormal, this tubular opacity, which is going outside the chest lung fields and going toward neck. So the pediatrician had a query that am I right now missing any pneumonia or something? Then the child was called upon, and then the hair braid was back upward, and we can see that there is no opacity in the lung. So we should be aware about that. External objects like outside the chest walls that can mimic like opacity or pneumonia, right? So just to give you a guide about the inspiration, because it's very important that whether the child has inspired properly or not. So usually, just for your understanding, you should count the anterior end of the thoracic ribs, starting from top to bottom, and ideally the sixth rib should intersect the mid-dome of diaphragm, which is happening in this case. So this is a properly inspirated film in which the sixth rib is touching the mid-dome of diaphragm. And this is the example of expiratory film in which your fourth rib is touching the mid-dome of diaphragm. So that's why it is causing a lot of artifacts and excessive haziness in the lung fields, which can mimic like a diffuse viral process or ARDS kind of appearance. The other thing that you should be aware about the normal thymic shadow. So usually the normal thymus has this kind of a very sharp and smooth lateral and the inferior opaque shadow on the epifilm as well as lateral film. And that's how we can differentiate a thymic shadow from the consolidation. These are few more example of normal thymus. So the normal thymus, in less than 2 years of age, it can be of variable sizes and shape. It can be seen on right side, it can be seen on left side. But the dictum is that it should not cause any mass effect or displacement of the important structures in the mediastinum. You should be able to see the lung vessels through it. So these are the normal findings of the thymus. And this is called as Sale sign. And this is called as a wave sign, because when wave is formed by when the thymus touches with the adjacent wave, it can cause this kind of wave kind of appearance. That is called the wave sign, which is also normal. So sometimes in OPD, the pediatrician they have doubt when they see this kind of abnormal as opacity. That am I dealing with some sort of normal thymus, or am I dealing with some mediastinal mass? So in those kind of scenario, when you want to save radiation by not doing CT scan, you can send a child for USG screening. Especially in pediatric population where the bony framework is not that much ossified, and we can see through the mediastinum through the parasternal route with the high frequency superficial probe. And when you see this kind of dot and dash kind of appearance in the mediastinum, that ensures that it's a normal thymus and it's not abnormal mass or something. So in that way, we are saving radiation also, and we are solving the doubt of whether it's a mass or pneumonia or it's a normal thymus. Just to give you the example, the normal thymus versus the consolidation. Here you can see that the normal thymus has sharp lateral margin, and the consolidation has very irregular fuzzy margin. So that is the differentiating point between the consolidations and the normal thymus, especially when they are seen in the paracardiac or paratracheal region. When there is some sort of massive pneumothorax and pneumomediastinum, it will uplift the thymus from the cardiac chambers, and you will see this kind of spin sign in which the thymus is elevated and uplifted. As we have seen in the basic side that you should start with the lung parenchyma, then focus on the pulmonary vasculature, then followed by the cardiothoracic ratio. You should always look carefully about the airway and mediastinum and bones and soft tissue. So I'll discuss some more time, around 10 minutes, regarding the different common clinical scenario that we can come across. We'll start with the unilateral lucent lung. So whenever you see unilateral lucent lung, that can be due to chest wall abnormality, or it can be secondary to lung parenchymal or airway or mediastinal abnormality. And these are the reasons. I'm not going to detail since wanted to show more cases. So when you see at the radiograph, first of all, you have to look at the age of the patient. So here is a neonate who has come with respiratory distress. So when neonate comes with respiratory distress, and when you are seeing this kind of abnormal cystic looking lucencies in the left hemithorax, and it is also causing the shift of the mediastinum towards the right side. That means that there is some sort of mass effect caused by this kind of cystic lucency. You can see that this is the trachea and the endotracheal tube. It is also shifted towards the right side. The other important thing that we have seen, that you should see the continuity of the diaphragm on both sides. You can see the continuity on the right side, but on the left side, we are not able to see the diaphragm. So that indicates that there might be defect or absence of diaphragm, and this cystic lucency can be bowel loops which would have herniated into the thoracic cavity. So that is the case of congenital diaphragmatic hernia. And CT scan was done because the child had some cardiac issues. So just to make you aware that these were the small bowel loops which are filled with gas and fluid. That was the case of diaphragmatic hernia which was repaired. Now here is another child, a 5 months old infant with history of breathing difficulty since birth. And here again, you have some sort of asymmetrical lucency in the left lung. Some cystic area is seen in the left, mid, and lower zone. That also looks like more of a congenital because the child had problems since birth. So another clue is that when the child is very young and the history is there from the birth or after a few months of birth, then you should also keep in mind that there might be some sort of congenital anomalous malformation which is involving the lung, which can give rise to this kind of cystic lucency. So further to make diagnosis, CT scan also was done, and CT scan revealed that that left lower lobe had one large cyst with air fluid level. But important thing to notice that the adjacent parenchyma also was not normal. It was having this kind of small cystic lunacy, and the lung architecture also was different from the rest of the normal looking lung. So based on this finding, we gave possibility of CPAM, that is the congenital pulmonary airway malformation, and that can be of microcyst or mixed variety. And finally, the left lower lobe was dissected. These are the surgical specimen which shows that large cyst and the lower lobe. So it was proven on histopath. The other thing that you should be aware about, very subtle clue on radiograph, when the child, like this 2-year-old child who had come with sudden onset wheeze, and this is the age group where the foreign body ingestion is very common in pediatric population. So, and not all foreign bodies are radio opaque, so you might not be able to see the foreign body itself, but you will be seeing some sort of secondary signs which may indicate air trapping or obstruction in the airway. So if you carefully see both the lung fields, you can see here that the left mid and lower zone, they are looking more lucent. And if you see that there is intercostal space widening also in this area. So this area probably indicate there is some sort of air trapping in that left lower zone, which might be secondary to airway obstruction, which could be a mucus plug or which could be an organic foreign body which the child has ingested. So this was the left bronchial foreign body, which was removed by endoscopy. Here is one child who had come from the racecourse area. The child was doing some horse riding and fell from the horse and came with respiratory distress. And this is the X-ray radiograph. The important thing to pick up is that you can see one vertical line which is separate from the chest wall, lateral chest wall, and you are not able to see any vessels within those area. So that indicates it is a pneumothorax, and that line is called as visceral dural line. And you can see that this is the air in the chest wall and the lower neck area, that is called as surgical emphysema. So this child had developed pneumothorax and surgical emphysema, which was subsequently treated. These are a few other signs of the pneumothorax. You can see that this is the postoperatic angle, which becomes more deeper and lucent. And sometime in supine position, you will be able to see that the mediastinal aspect of the diaphragm or the cardiophrenic angle becomes more lucent as compared to the opposite side. And that part of the lung will show abnormal deepening of the left apical sulcus. So these are the signs of the pneumothorax. Now, just for the interest of time, just going you through the few more cases in which now we'll come to the another category, that is the unilateral opaque lung. That also is a common finding that we come across in our routine day-to-day scenario. So that opaque lung can be effusion or it can be a collapse or hypodeveloped or non-developed of the lung, or it can be obstruction of the vein bronchus. So this kind of scenario, how to deal it, that we'll be seeing by this example. So here again, you have to see that a 2-year-old child who had come with acute respiratory distress. And what we can see here that there is volume loss in the left hemithorax. You can see that the metastable structures and the heart shadow, they have shifted towards the left side. And if you carefully see that this is the left main bronchus, and there is a sudden cutoff of the left main bronchus, and followed by you are seeing this kind of homogeneous opacity which is lying in the left hemithorax. So when you are seeing that the metastable structures are shifted towards the same side, that indicates that there is some sort of volume loss in that lung. So you should not tell as a massive pleural effusion or empyema in this case, because all the structures are shifted towards the same side. So these are the CT images in which we can see that this is the right main bronchus level and that is the left main bronchus level. So in the left main bronchus level, we are seeing this filling defect, and that was the cause for the collapse of the lung. And these are the reconstructed images which shows the same finding. And subsequently, bronchoscopy was done, and which revealed that the child had this kind of a mucus plastic cast, which was obstructing the left main bronchus, and that was causing collapse of the entire lung. Here is one of the example which is opposite of what we saw. In this, we can see that large homogeneous opacity occupying the left hemithorax. In addition, what we can see that this is the air bronchogram, which is the air-filled segmental bronchi within that opaque lung, which indicates pneumonia. And in addition, you can see that the metacenum is shifted towards the right side. There may be element of some sort of pleural effusion or empyema. So in this kind of scenario, we should do USC as a second step. And these are the USC images in which we can see that internal septations and that pleural cavity was showing thickening of the pleura in the surrounding with this kind of low level floating echoes and very complex pleural effusion that we label it as a empyema. It's very important to see the complexity of this empyema because take that will guide the further management that whether the ICD has to be put or the child goes for VATS, that is the fluoroscopic procedure to peel off all the necrotic or damaged tissue. So that's what the pleural empyema. Not all opacities are pleural effusion and pneumonia. Just to show you that here is one homogeneous opacity which is lying in the right hemithorax. But if you carefully see that here, the fifth rib, the lateral part, it shows this kind of irregular lytic sclerotic area. Plus, you can see that this abnormal soft tissue bulge in the chest wall. So that might be the clue that we are dealing with some sort of chest wall pathology. And you can screen on USD just to look at we are dealing with some sort of abscess or osteomyelitis, or we are dealing with some soft tissue lesion. So in this case, we can see that it was a solid lesion which is having increased vascularity. And subsequently, CT scan was done, which was showing this kind of large doubleted mass, which was arising from that rib. That rib was showing sclerosis and periosteal reaction. So that was a case of Ewing sarcoma on biopsy. So here is another important thing that as a general pediatrician or intensivist, you should know that how to diagnose tension pneumothorax. So the tension pneumothorax will have this kind of large air-filled pleura, which will displace the diaphragm inferiorly, and it will cause collapse of the lung. So this abnormal opacity, what you are seeing here in the middle part, that is the collapsed lung, and you will see this kind of bulging pleural cavity inferiorly. So that's a sign of pneumothorax, tension pneumothorax, which requires immediate intervention. Uh, Now, just to show you, yeah, so these are some clues to remember when you are reading a chest radiograph. First of all, whenever a child comes to you, you always review the older X-ray because sometimes when you see any abnormal opacity which is lying in the persistent area or any pneumonia which is occurring in that same recurrent location, that means that that anatomical area might be having problem, which might be congenital or it can be showing some sort of obstruction. So one prime example of that condition is intralobar sequestration. Here is one child who had recurrent cough and infection since early childhood, and what we are seeing here is that abnormal airspace requested in the right lower zone, which was persisting and which was seen in earlier radiograph also. So subsequently, CT scan was done, which revealed that it was an intralobar sequestration, and that you can see that there was a systemic vessel supplied to that abnormal looking area, which was confirming that this was the intralobar sequestration. The other thing that you should be aware that when the anatomy is pertaining to a particular area, then you might be dealing with foreign body. When you see unusual esophageal dilatation, then you might be dealing with fistula, stricture, or eclasia. And when you see that the opacities are multiple in different locations, then you might be dealing with some sort of immunodeficiency disorder or systemic cause. So that was a brief about how to interpret or go about chest radiograph. So I had more slides, but due to interest of time, I'm just stopping the presentation. Now I would like to invite my colleague, Dr. Sonal Garg. She will be taking you through the world of fetal imaging. And yeah, I'll invite her. She's also with us full time in our hospital and trained in pediatric radiology as well as fetal imaging, and a great help and a great person. So without wasting much time, I would like to invite Sonal Garg to take over.
Yeah, good afternoon, everyone. So Dr. Hiren took you through pediatric chest X-ray, and now we will actually go back in time. In this pediatric hospital, we not only look after the fetus, but we also look after the mother. And as we all know that the fetus is the first starting point of a pediatric patient. And so this is what comprehensive healthcare is about. So maternal and fetal imaging is one of the most important aspects of pediatric radiology because as we all know that early diagnosis of problems improves outcomes. When we detect a problem, it can guide our obstetric decision making. It is very essential in emergencies and it can help choose how and where we can deliver the baby and what is the immediate intervention that will be required in the neonatal period. Now, as we all know that becoming a mother is not the easiest thing today because there is a very high incidence of infertility. The approximate prevalence in India is almost 18.7 per thousand women. Preliminary visits to the gynecologist always includes a basic pelvic ultrasound, which includes both a transabdominal scan and a transvaginal scan. So the diagnostic scope of of a ultrasound before the mother becomes pregnant is to detect congenital anomalies of the uterus like uterine didelphys, bicornuate and unicornuate uterus, which may be preventing the pregnancy. Other conditions like adenomyosis and endometriosis, which may also be contributing to infertility, polycystic ovarian disease, in which we can also do follicle study for follicle monitoring. So these are the images that show us conditions like in polycystic ovary disease, which is a typical condition very common nowadays, where both the ovaries are enlarged and they have multiple small follicles arranged peripherally with a very raised central stromal echo texture. And this is the characteristic imaging appearance of a polycystic ovary. Then we can see all sorts of complex cysts in the ovary, but these type of cysts which have dense internal echos and not much vascularity are very likely to be endometriotic cysts. Then the congenital anomalies of the uterus that also contribute to infertility, like a bicornuate uterus or a uterus didelphys, which can be seen with advanced ultrasound imaging as well as MRI of the pelvis. Then conditions like adenomyosis, endometriosis, or submucosal large fibroids, where the patient does complain of a lot of irregularity of the menstrual cycle, heavy bleeding, pain in the abdomen while bleeding, very severe dysmenorrhea. So all these can be picked up both on ultrasound and MRI. And now there are a lot of non-invasive techniques to treat these conditions. So as to improve the chances of conception after the procedure is done. So the imaging modalities is mainly ultrasound, MRI, and CT. Ultrasound is the primary tool for both the mother and the baby as it does not involve any ionizing radiation. MRI can be used as an adjunct as a problem-solving tool when required because it also does not have ionizing radiation and is safe for both the mother, a pregnant mother, or a fetus. And the next is the CT scan, which of course does have ionizing radiation, but sometimes in the case of emergencies, especially maternal emergencies like trauma, etc., it may be life-saving. So when do we image in pregnancy? The first trimester scan is usually a viability and dating scan. The second trimester is a detailed anomaly scan. And the third trimester is for fetal growth and placental imaging. So these are the advantages and limitations of each of these modalities. Ultrasound is a safe bedside investigation with real-time imaging. However, the limitations are that it is operator dependent and hence You need a good level of skill and expertise to interpret and to reach a good proper diagnosis. MRI has excellent soft tissue and spatial resolution, but it is shrouded with problems like motion artifact of the fetus. Of course, the cost is much higher and it is not easily available. CT is extremely fast, very widely available, but very high radiation risk. So it has to be reserved only for maternal trauma. Now, the common indications for fetal and maternal MRI are when there are any abnormalities picked up in the fetus on the antenatal ultrasound imaging. And in maternal, the placental abnormalities, and even in medical emergencies like appendicitis or hydronephrosis or a liver abscess or any of these, we can resort to an MRI. So how do we approach a fetal abnormality that is detected on ultrasound? So typically the anomaly scan, which is done between 18 and 22 weeks, will pick up an anomaly in the fetus, which you need to confirm and characterize, preferably by two level 2 ultrasound radiologists. And after that, we refer them for a targeted fetal MRI. So the ultrasonologist tells us that this is what I am suspecting. This is where the problem is. So we do a very targeted fetal MRI only to look at that particular part, characterize the anomaly, and then of course screen the rest of the fetus. And that helps us to both counsel the parents, and if any further genetic testing is needed, like an amniocentesis or a karyotyping or a chromosomal assay, and also to plan the delivery and neonatal care in a specialized unit that can look after the child that has that particular ailment, and it can guide us with planning the future pregnancy for the mother. So what is the role of fetal MRI in clinical practice is to get that complementary information and what will be the consequences. So when you pick this up before 24 weeks, you can actually help the parents make a decision for termination of the pregnancy or to continue the pregnancy, as most structures are well visualized at this gestational age. But when it is performed after 24 weeks, it is mainly for prognostic purpose and for decision making about the delivery. However, this is one thing that I would like all of you to take note, that the amended MTP Act in 2021 does allow fetuses beyond 24 weeks also to be terminated if they have substantial fetal abnormalities which would be incompatible with age. So 24 weeks is no longer a hard stop for the MTP. So this is the first trimester imaging, which is done by a transabdominal or a transvaginal ultrasound, where we confirm that there is an intrauterine pregnancy, that the pregnancy is viable, that you can see the heart rate and the heartbeat of the fetus. You can date the scan, especially when the person has an irregular menstrual cycle or does not remember the last menstrual period. It is used for ruling out an ectopic pregnancy. If the urine pregnancy test is continuously positive and you are not being able to see an intrauterine pregnancy, and then as the pregnancy advances, the 11-week scan, which marks the end of the first trimester, gives us the very important nuchal translucency scan, where we look at the nuchal translucency, the nasal bone, and the ductus venosus of the fetus, which are all soft markers for chromosomal anomalies. Then we move on to the second trimester imaging, which is typically done between 18 to 22 weeks. It is a detailed anomaly scan and should be done by experienced personnel only. After that, we do always call the patient between 22 and 24 weeks for a detailed fetal echocardiography and to see the morphology of the face of the child. At the same time, we do the biometry to make sure that the fetus is growing adequately, and a detailed sonogram of all the parts. Now I will show you some interesting fetal cases that we had in our institute. So this is a case of fetal ventriculomegaly, where the diameter of the lateral ventricle was more than 10 millimeters. And this patient was actually a doctor herself. So she was extremely nervous when she was told that her fetus has ventriculomegaly. And so she insisted on undergoing a fetal MRI to ensure that there was no other anomaly. And we were happy to report that the MRI was completely normal and the baby is also normal, and the ventriculomegaly has been stable since birth. This is another patient who was a 28-year-old primigravida. At 19 weeks, she was told that the baby has fetal ventriculomegaly. And on ultrasound, we could see very clearly that the cavum septum pellucidum was absent and there was complete corpus callosum agenesis. So the mother decided to terminate. This was another fetal MRI done for ventriculomegaly. So the mother was told at the 18-week anomaly scan that she has ventriculomegaly and suspicious partial agenesis of the corpus callosum. So she chose to undergo an MRI, and this did confirm that there was partial agenesis of the corpus callosum. And in addition, there was a sulcation abnormality that was detected in the left frontal lobe, which was very suspicious for a focal cortical dysplasia. So yes, fetal MRI does help you characterize the abnormality further and perhaps pick up another abnormality or associated anomalies, which helps guide our decision making better. It also gives the parents more information and confidence whether they should continue or terminate. This is yet another case of fetal MRI for ventriculomegaly. A 30-year-old lady came, and at the routine 18-week anomaly scan, there was colpocephaly with partial agenesis of the corpus callosum. But when we did the MRI, we also found semilobar holoprosencephaly in addition. So this was not very good news. This is another case of fetal ventriculomegaly showing you a spina bifida defect with a myelomeningocele and ventriculomegaly, which is the typical finding of an Arnold-Chiari malformation type 2, which was diagnosed in the fetus. Then MRI is also very robust for picking problems of the posterior fossa, like in this particular fetus. The ultrasound showed a dilated posterior fossa, and they could not make out whether this is a Dandy Walker malformation or is it just a dilated cisterna magna. But when we did the MRI, we could see the septum separating the posterior cisterna magna, and that was very pathognomonic of a posterior fossa arachnoid cyst, which is very amenable for surgery in the post-operative period. Now again, for fetal skull, face and neck anomalies, MRI is a very good technique, as is ultrasound. But when the fetal position is not favorable or the baby is constantly covering his face with the hands or the legs, then fetal MRI would score over this, where we can in real time measure all the angles of the maxillofacial region and give the accurate diagnosis of retrognathia, micrognathia, and all the other anomalies of the face and neck. Then this is a patient who was referred at 24 weeks gestation because she had an echogenic mass in the fetal abdomen, which was suspected to be a malignant neoplasm. They had given the possibility of a congenital neuroblastoma, which is a very sinister diagnosis. But when we did the MRI, we found a large hypointense mass with a distinct vessel arising from the aorta. And this, we concluded, was an extralobar infradiaphragmatic pulmonary sequestration. So fetal MRI is also an absolutely robust technique to diagnose, detect, characterize masses in the thorax and the abdomen. This was yet another patient, 26-year-old weak gestation, who had antenatal diagnosis of hydronephrosis. Both the kidneys were showing these large cystic areas, and there was severe oligohydramnios, making it very difficult to image the fetus properly. The ultrasound did show very severe hydronephrosis, which was more severe on the right side. And when we went ahead with the MRI, we actually saw that this was not bilateral hydronephrosis, but the right kidney, in fact, had multiple irregular cysts of varying sizes, which we concluded was a multicystic dysplastic kidney, while the left kidney had dilatation of the pelvic calyceal system and ureter its entire extent. So this was a bilateral renal problem, and the parents chose to discontinue the pregnancy. Now moving on to imaging for the mother. So placental imaging has also really advanced now. So before, problems like placenta previa and the placenta accreta spectrum, which includes placenta accreta, increta, and percreta, based on the amount of penetration of the placenta of the uterine wall. has also is now being picked up far better and more frequently by using ultrasound and MRI, which actually tells you the invasion, the depth of invasion. So in this patient, you can see that there is a low-lying placenta, which is a placenta previa. But in addition, the placenta has completely infiltrated the uterine wall. And this helps us to plan the delivery. Patient can opt for a cesarean section instead of undergoing the ordeal of very severe postpartum hemorrhage. Now, again, moving on to imaging the umbilical cord of the fetus. So as we all know that the umbilical cord usually has 3 vessels, but a 2-vessel cord means that there is an absent umbilical artery or a single umbilical artery, which is also, as we all know, associated with many chromosomal anomalies. You can also pick up cord insertion anomalies and vasa previa. Then the amniotic fluid abnormalities, as we know, could be both including less amniotic fluid, which is oligohydramniosis, and extremely high amniotic fluid, which is polyhydramnios. And both these conditions also point towards multiple underlying problems in the fetus, like fetal renal issues, bladder outlet obstruction, and oligohydramnios, and problems of the face, neck, and the orodigestive tract in polyhydramnios, where the child is not swallowing the amniotic fluid. So this is a case of a patient with very severe polyhydramnios, and on ultrasound, we could not see the stomach, and you can see a zoomed out view of very severe polyhydramnios in the child. The 2D ultrasound B mode also showed a cardiac abnormality. There was overriding of the aorta, there was a ventriculoseptal defect, and there was a pulmonary stenosis. And echocardiography with color Doppler showed that this child had tetralogy of Fallot. So the patients opted for doing a fetal MRI because we saw so many anomalies, and we thought, let us see if we can characterize this further. And the fetal MRI indeed did show a short neck with fused vertebra. And the final diagnosis was a Vactor-L spectrum. As you know, Vactor-L consists of these 7 systems that may be involved, and at least 3 need to be present for the diagnosis to be considered. Then moving on to the 3rd trimester imaging, which is mainly done for fetal growth assessment, where we do the fetal biometry, and with that you can estimate the fetal weight. If there is an issue, we can say whether there is a symmetric versus an asymmetric IUGR. And of course, the role of Doppler, which significantly contributes to the diagnosis and early monitoring of any baby who is undergoing IUGR, and we can terminate this pregnancy earlier, bring the baby out and manage the baby better if there are vascular problems. So in the 1st trimester scan, that is 11 to 12 weeks, we can do a very early uterine artery screening. By the end of the 1st trimester, the diastolic notch typically starts disappearing. Then in the 2nd trimester, we again continue to look at the uterine artery. But in the 3rd trimester, we actually see all the other parameters like the umbilical artery, the fetal middle cerebral artery to know whether there is adequate perfusion of the brain, the fetal aorta, and the fetal ductus arteriosus that significantly help in making that decision on management of the child. So for example, this is a normal umbilical artery Doppler where you see that there is continuous diastolic flow, and the S/D ratio typically lies in the range of 3 to 3.5. But this is an abnormal umbilical artery Doppler where there is complete reversal of flow in the diastole. So here you know that this baby is hampered. The blood is not, there's a uteroplacental insufficiency, and the baby needs to come out ASAP. Now, the next very useful area nowadays is multiple pregnancy. As we know, assisted reproductive techniques have greatly increased with a much higher incidence of twin pregnancies. So imaging is definitely imperative for these pregnancies, where you can determine the chorionicity, early detection of other complications like polyhydramnios, oligohydramnios, twin-to-twin transfusion syndromes, and congenital anomalies of the fetuses itself. We have seen a higher incidence of anomalies in the IVF babies. Then the maternal acute abdomen, where again ultrasound is always preferred. Then if that doesn't give us the diagnosis, we can try MRI and really reserve CT scan for the worst case scenario, unless the mother is really unstable and cannot undergo an MRI. So the typical causes of acute abdomen like appendicitis, cholecystitis, ovarian torsion, hydronephrosis, hydroureter, urinary calculus, which we have seen in pregnant mothers. When we do image a mother for trauma, you typically do a fast, a very focused ultrasound, CT only if needed, and that too with complete abdominal shielding. And studies have shown that if you do a head CT scan or a chest CT scan and you cover the abdomen with adequate lead shielding, it's typically safe even for a pregnant woman. So over the past 40 years or so, antenatal imaging has come a long way from actually imaging the womb to the baby immediately in the postnatal period. And the role of the radiologist is to thoroughly screen the mother and baby in utero using a very robust checklist, make sure that every part of the fetus is looked at in detail, pick up the anomaly or the associated soft markers. And when you find one anomaly, make sure you look for more because typically that is the case. Ask for more frequent follow-up imaging if doubt persists because a lot of these structures are dynamic, including the fetus. The fetus is also constantly moving. So don't hesitate to call the mother back if you need to. Ask for additional imaging if you are unsure, like fetal MRI, which will also help to problem solve. So please, as we all know, we had a subject called PSM at MBBS, which we all refused to study. But today, as a maternal and fetal hospital, we always, practice preventive medicine first because every journey matters. With that, I will now invite our fellow, Dr. Jithin Johnson, who has been with us for a year, and he's ready to take on the world of pediatric radiology, and he will talk to us about the fluoroscopic procedures in pediatric patients.
In the next 20 to 30 minutes, I'll be going. So in the next 20 to 30 minutes, I'll be going through the role of fluoroscopy in pediatric imaging. So fluoroscopy basically means it's a type of dynamic imaging where we use X-rays to visualize the internal anatomical structures and to assess the function in real time. One downside is the ionizing radiation, but however, there is the benefits which it offers in terms of diagnosis and management. It outweighs the potential risk. So, and moreover, it is used very judiciously with appropriate dose reduction strategies as well. So these are three main, the most common systems where we use fluoroscopy. The studies being a barium swallow, barium needle upper GI study, barium follow through, barium enema distal hologram. Whereas in the GU track, the fluoroscopy studies used are MCU, IVU, nephrostogram, etc. And finally, in the respiratory system, we can use fluoroscopy for assessing the airway as well as the diaphragm. So let's start with MCU. So the basic indication for MCU is mainly to look for vesicular reflux, to assess the urethra during maturation, to see for any bladder leak, post surgery or trauma. The contraindications being an acute UTI. But we do this procedure under antibiotic cover, or if the child is not already on antibiotics, we have the system here to administer the antibiotics and then take the baby. And the two phases, main phases, which we concentrate are the filling phase and the voiding phase. And IVU, it currently has a limited role as it is currently superseded by CT urography and MR urography. Previously, the indications used to be hematuria, renal colic, recurrent UTI, suspected UTI, especially genital urinary TB, etc. So let's start with the normal anatomy. This is the normal urinary bladder, which is smooth, well-defined, smooth contours, well distended.
Um, Excuse me, sir. Actually, the screen is not visible. I can only see the file explorer. If you can turn on the PPT, it would be easier.
Yeah, sure.
Sir, you're on mute.
I hope my screen is visible and audible.
Yeah,
Yeah,
you're audible, but we missed the previous slides actually. If you can
sure,
just go through them quickly, it
sure,
would be nice.
sure. Slides move and so, just to recap, so fluoroscopy is a type of dynamic imaging in which we use X-rays to visualize the internal anatomical structures and they assess their function in real time. So the main systems which we cover using fluoroscopy or assess fluoroscopy is in GIT, GOT, and respiratory system. The studies being as follows. Then to talk about briefly about MCU, the common indications are to look for vesicular ureteric reflex to assess the urethra during maturation, to look for any bladder leak, whereas the contraindications are an acute episode of UTI. And the preparation is usually that is done under antibiotic cover, and it is to be continued for 3 days. And the two phases which we concentrate on is the filling phase as well as the voiding phase. IVU has a limited role nowadays because it is superseded by CTU and MR urography. Previously the indications used to be hematuria, renal colic, recurrent UTI, other pathologies like genital urinary TB as well. So this is how a normal bladder looks. So we can see that it has smooth, well-defined, smooth contour, is well distended, and just to compare between a female urethra and the penile urethra, male urethra. So the female urethra is very short and straight course, whereas the male urethra is divided into anterior and posterior urethra, which comprises of the penile and the bulbar part, as well as the membranous and the prostatic part. So let's see some cases. This is a case of prostatic urethral valve, where we can see that there is a posterior dilation of the posterior urethra, as well as there is irregularity of the bladder contour. And we can also see that there is a shelf-like lucency around the bladder neck. So next, let's see some cases. So this is a 9-month-old which came to us with bilateral hydronephrosis. So what do we see here is that this is after the filling phase. We can say that the bladder is distended. The bladder contour is irregular with triangulations. You can see that there is bilateral ureteric, vesicular-ureteric reflex on both sides with some blunting of papilla, but still the papillary impressions are still maintained. So this is a grade 4 bilateral vesicular ureteric reflux. And what else do we see? We also see that there is this spinning top kind of appearance here, which indicates the dilated posterior urethra and narrowing distal to that. This is a classical appearance of posterior urethral wall. Next is a similar case. It was a 5-month-old baby with a history of recurrent UTI. So what do we see here is that we see that there is an abnormal insertion of the left ureter into the prostatic urethra. So this is a ectopic insertion of urethra, left ureter into the urethra. And along with that, there is again a dilation of the posterior urethra, suggesting of a partial posterior urethral valve. So again, some more cases, we can see that what we see in this MCU is that there is a filling defect adjacent to the bladder base and also vesiculated reflux on the left side. So on ultrasound showed us as a hypoechoic lesion. So this is a classical appearance of a ureterocele, which is in this case is associated with a left grade 3 to 4 vesiculated reflux. So this is just to show you that sometimes we also find these contrast-filled outpouchings lateral to the bladder ureteral insertion. So this is a paraureteral ureteral diverticulum, along with again you can see in this case also the posterior urethra is dilated, suggesting a posterior urethral valve. So this is a typical appearance where patient. This patient was a 7-year-old who came to us with a known case of gross spinal dysraphism and partial sacral agenesis. So we can see that the sacrum is not well developed, and the bladder is elongated, and you can see the trabeculations and the irregular contour of the bladder. So and the child was not able to void on his own. So this is the typical appearance of a neurogenic bladder. So this is an interesting case. This was a 2-year-old with a history of bladder extrophy who had undergone a repair for epispadiasis as well. So he came to us for evaluating or assessing his bladder volume. So once we catheterized the child and filled his bladder, so we could see that there is a reflux on both sides as well. And once the child started dribbling, we could also notice that there is a separate tract adjacent to the tract which we had catheterized. So in this also we will be able to see. So this was a suggestive of either a partial duplication of the posterior urethra or a bifid posterior urethra. So this is just for completion's sake because IVU we administer contrast intravenously and then acquire radiographs in the intervals to assess the excretion of the contrast into the pelvic helicity system. So here these are spot films taken at 5, 20, and 2 hours. So what we can see is that on the left side there is ballooning and dilatation of the pelvic helicity system. However, we are not able to see the left ureter. It is not opacified and there is progressive dilatation. Whereas on the right side, we are able to see the right ureter and the normal appearance of the pelvic helicity system. On the left side, the chelices are there is blunting of furnace, but there is still some papillary impressions which are maintained, so suggesting a grade 3, grade 4 hydronephrosis. And the fact that we are not able to see the rest of the urethra on the left side suggests that this is a left UG obstruction. So nephrostogram is a post-op evaluation technique where we inject dye through the indwelling catheter, which is already inserted into the dilated pelvic helicity system, and we inject water-soluble dye. So here we can see that it is ballooned out. There is gross hydronephrosis, as well as there is tortuosity of the left ureter, which is dilated. And another point is that it, as we come towards the distal ureter, where it inserts into the bladder, we see that there is this peaking or narrowing, suggesting a stricture at that side. So briefly about barium or oval contrast study. So the indication is basically in cases of suspected esophageal pathology like feeding difficulty, dysphagia, or dinophagia, motility disorders to assess for tracheoesophageal fistula, or in case of post-op assessment. So the contrast which we use are either a barium or a water-soluble oral contrast, which can be either a high osmolar like gastrographin or a low osmolar like Omnipac. So the point to keep in mind is that we do not use barium in case if we suspect a perforation. to avoid any barium which can cause mediastinitis. And as well as the gastrographin, which is a high osmolar contrast media, is avoided in case of if we suspect that there could be aspiration that acid can lead to pulmonary edema. So briefly on the technique, we use anterior and lateral projection for dynamic evaluation of the esophagus. And moreover, we can take dedicated view of the hypopharynx also in AP and lateral projections for the swallowing phase. And if there's any dysmotility, particularly and if the dysmotility is suspected, we can mix the barium with biscuit or bread so that if the child is having dysphagia towards solid, we can, according to the history, we can modify this and evaluate the passage of bolus. And another method which we use for assessing tracheoesophageal fistula is a pullback method where we insert a rice tube and we distend the stomach and we withdraw the without the rice tube and so that the tip is within the esophagus and then we push the contrast with pressure so that we can get an adequate distension of the esophagus so that we'll be able to identify any small fistulas as well. So in barium meal is usually to evaluate for vomiting, to rule out other causes like pyloric obstruction, malrotation. We look for gastroesophageal reflux. And for as part of preparation, we ask the patients to be fasting for a period of 1 to 2 hours before the examination. And briefly on the technique, a small contrast is given to adequately distend the fundus. And we keep the position, the patient in such a position that we track the contrast across the into the duodenum and the DJ flexure just to make sure that there is no obstruction or malnotation. So once that is ruled out, we can go ahead and give a complete or adequate amount of barium to distend the stomach completely. And additional maneuvers are used to coat the gastric walls and to get a good mucosal coating. So and various views are taken to demonstrate the gastric anatomy as well. So to assess for reflex, what we do is we keep the patient in different positions like in prone position or in a head low position. And also we can ask the patient to swallow water. This is called as the water siphons test to see for the reflex. So, and regarding small bowel follow through, the basic indications are diarrhea, partial obstruction, malabsorption, or to evaluate for a transit time. And the contraindications being a high grade or a complete obstruction, or in cases of suspected perforation. And the technique is simple, similar. We would like to give a complete good amount of barium to at once and spot films are taken every 15 to 20 minutes in the first hour and subsequently every 20 to 30 minutes until the contrast reaches the pole. And additional dedicated views also can be taken to demonstrate the IC junction or in case if delayed images can also be taken at 4 hours, 24 hours according to the indication. So finally, a bit about the barium contrast, barium or contrast enema. The indication is particularly in case of neonatal low intestinal obstruction for if there is any suspected large bowel pathology to evaluate for chronic constipation, etc. And contraindications are suspected perforation, toxic megacolon, pseudomembranous colitis, any history of recent biopsy, incomplete bowel preparation, etc. So here we ask the child to lie on the left side and we insert the catheter and the barium is administered to assess the rectosigmoid in the left lateral position. And further, the passage of the barium is followed through and the additional maneuvers are used to trace the passage of the contrast all the way up to the IC junction. So we'll see some cases. So this is a case of, as you can see, this is a case of barium swallow where we can see that the reflux of the barium is going up to the level of cervical esophagus. So this is a case of grade 3 GERD. So grading is according to the level till which the barium reaches. So if it is grade 1, if the barium reaches up to the distal esophagus, it is grade 1. If it reaches up to the level of the carina or above the carina, that's grade 2. And if it is reaching up to the cervical esophagus, that's grade 3. And if it is the oral cavity, that's grade 4. So next is a case 1-month-old with history of parental asphyxia and feed intolerance who had come to us for evaluation with the oral contrast swallow. So here we can see that once the as the baby is swallowing, there is a couple of contrast which is going into the nasopharynx. So this is a nasopharyngeal reflex, abnormal nasopharyngeal reflex. As well as you can also see that while the baby is swallowing, you can see that there is the contrast coating along the walls of the tracheobronchial tree, which suggests that there is aspiration of the contrast as well during swallowing. So this is another child, 2-year-old, who is a known case of tracheoesophageal fistula, who was operated and who came with swallowing difficulty. So he underwent a recent dilatation procedure as well for stricture. So when he came to us, once we administered the oral contrast through a second Rice tube, and with its tip in the mid-esophagus level, what we can see is that there is a defect here in this mid-esophagus level, and we can see this there is active contrast leak which is holding within the mediastinum as well as the left pleural cavity. This is a zoomed up image which shows the same thing, the defect in the left lateral wall, as well as the contrast which is leaking into the pleural cavity as well as the mediastinum. So this was a case of esophageal perforation. So this is a very classical image. This is malrotation of bowel. So what do we see here is that there's normal contrast uptake within the duodenum. But as we see that there is no normal, normal crossing of the duodenal loop across the midline is not there. And we see that there's further pacification of the jejunal loops happening, which is predominantly on the right side of the abdomen. And further in the delayed films, you can see that the biliary loops are more towards the left side. So this was a case of malrotation of bowel. So here is another case of a 1-year-old 4-month female child who's a Down syndrome, who complains of feeding difficulty. So during the barium study, what we saw was this sock-like appearance or in the part of the duodenum. So this is also known as the windsock sign, which is due to the ballooning of a duodenal web. So this was a case of duodenal web, and you can see that as the contrast is ballooning or pulling into the web, it causes it into the duodenal lumen. It causes this kind of appearance, also known as the windsock appearance. So this is next is a case of congenital hypertrophic pyloric stenosis. For this, usually the initial evaluation is with ultrasound. So, but we can do a barium study in case the ultrasound is equivocal. So, so here we can see that this is the thickened pyloric canal, and what we can see is that there is trace contrast, the contrast pulling within the stomach, and there is trace contrast which is going along the pyloric canal, and there is some contrast uptake happening at the duodenal bulb. So this sign is called as the double track sign, as well as there is this appearance here of the duodenal bulb is called the mushroom sign. So this is classical human CHPSS. So this is another 3-year-old who came presented to us with the history of blunt trauma abdomen. So on ultrasound, what we could see was this hematoma in the region of the duodenum. So this was a duodenal wall hematoma, and he could not tolerate any oral feed. So we did this procedures to assess the degree of obstruction. So what we can see here is that the stomach is distended with the contrast, and here at the part of the second part of duodenum, we can see this dome-shaped filling defect. Here also we are able to see this dome-shaped filling, and there's no prompt passage of the contrast across this second part of duodenum. However, in the delayed one-hour films here, we can see that there is contrast affection in the rest of the small bowel loops. So this helps us understand that this was not a complete obstruction. This was more of a partial obstruction. So this is another child. This is a very classic film showing of a 10-year-old with bilious vomiting. So what we can see here is this classical corkscrew appearance. And also here also we can see that there is no normal crossing of the third loop of the duodenum. The duodenal loop or the third part of duodenum, and the contrast of pacification in the jejunal loops. So this is a case of malrotation with midgut volvulus. So this is another interesting case of a 10-month-old who was a known case of cystic fibrosis. who presented with non-passage of stools and continuous vomiting for past 2 days. So here we can see that the radiograph showed multiple air fluid levels, as well as there is a positive bowel gas in the pelvis in the rectal region. So in this case, what do we do? So this is a algorithm, this particularly for neonates with suspected of bowel obstruction. So what we primarily have to do is based on the appearance of the abdominal radiograph, we have to classify it into either a upper obstruction pattern or a low obstruction pattern. That is, if it is upper pattern, that what we mean is that if the obstruction is prior to the level of the ileum. If it is a low type, if it is a low grade obstruction, that is, it is a low grade obstruction, it involves either the ileum or the colon. So if once we identify that, we can proceed ahead. If it is an upper GI problem, so we can go ahead with a fluoroscopic upper GI study. Or if it is a lower GI obstruction, then we can proceed with fluoroscopic enema. So in this case, we proceeded with the GI enema, I mean the barium enema. So where we can see that there is normal caliber of the rectum, rectosigmoid, and the descending and the transverse colon. But as you can see that here in the right hypochondrium, in the proximal transverse, there is abrupt cutoff there. There is the contrast is not going ahead into the ascending colon, suggestive of either an intraluminal obstruction or an extension compression here. So this patient was managed conservatively, and this obstruction was due to meconium ileus, which is known with cystic fibrosis. The meconium flux that is known as cystic fibrosis. So this is another case, another case with of a 11-month-old with presented with a history of bilious vomiting. So the most marked thing, the most remarkable thing which we can see here is the diffusely small caliber of the rectosigmoid, and the transition across that towards the rectosigmoid, it gradually gains caliber. And you can also see that compared to the ascending colon, the descending colon is relatively smaller than caliber. But however, the transverse and the ascending is diffusely dilated with inspissated stool. So this is a case of Hirschsprung's disease, the short segment Hirschsprung's disease involving the rectosigmoid. And this is a companion case where you can see that the entire rectosigmoid, the sigmoid, the descending, the transverse colon, the entire colon is diffusely narrow in caliber with paucity of frustrations. So this was a case of long segment Hirschsprung's disease, where you can see the ascending colon is relatively normal in appearance. So coming to the last few cases, this is a 2-month-old who was a known case of anorectal malformation and who had undergone a colostomy. So in these images, what we can see, this is a distal cologram where we catheterize the distal colon and we inflate the bulb, which you can see here. And under pressure, which we inject water-soluble dye. And what we can see is that this blind ending rectal pouch, and also in the delayed films, once the pouch is adequately distended, we can see this abdominal sphincter tract, which is like communicating with the urethra. So this was a case of anorectal malformation with rectal vulva fistula. Another thing is that here we can use these two lines to assess what with a high type of Hiren or a low type based on this pubococcygeus line, which is drawn from the coccyx to the pubis. So if the rectal pouch is below this line, this is a low or intermediate variety, and if it is above, it is a high variety. So finally, this is a 3-year-old which came to us for evaluation of chronic cough, and what we saw was that there is on the left diaphragm is elevated, and there is what we can see is that this abnormal position of this antrum and the pylorus, which is very much higher than the gastric region as well as the GE junction. So this is the level of the GE, whereas this is the antrum pyloric junction. So we can see that there is abnormal relation, and more of the stomach is extending into the thoracic cavity, and the left diaphragm is elevated. Also on fluoroscopy, you could see that the diaphragmatic bone on the left side was very much decreased. So this was a case of diaphragmatic eventation with mesenteroaxial volvulus. So I hope I was able to cover the most common procedures, fluoroscopic procedures in the pediatric. And thank you for your patient listening.
Okay, so with that, we will now move on to our next segment, which is the interesting multidisciplinary cases that we have tackled in our hospital. The topic of this segment appropriately is small children with big diagnosis, and you will now see how and why. Okay, so for this first case, we have Dr. Supratin Sen, who is our senior consultant pediatric cardiologist, who will be presenting this case in conjunction with our nephrology team, rheumatology, and radiology.
To all of you. So this was a case which truly was a multidisciplinary effort to make a diagnosis and for the treatment. So this was a 10.5-year-old child who I first saw last year, and he had a history of severe pulmonary stenosis detected after birth, and balloon pulmonary valvotomy was first done at about 8 months of age. When I saw him last year, he had a restenosis of his pulmonary valve, and so he had a repeat balloon pulmonary valvotomy done last October. During that hospital admission, we also detected that he had systemic hypertension, and he was started on metoprolol. Thereafter, his follow-ups were a bit irregular, and he represented to us in May this year with severe epigastric pain. So that time he was seen by a gastroenterologist, and I also saw him again both for his persistent hypertension, which was not responding just to metoprolol. So during that admission, we added on amlodipine and enalapril in addition. And when we did a repeat echo, we saw that although the pulmonary valve had opened up well, there was significant infundibular pulmonary stenosis, which is something we can only treat surgically. Also, during this echo, we detected that his coronary arteries were looking exceptionally dilated, something similar to what we would see in a Kawasaki disease patient. But this age and presentation was not fitting into Kawasaki, obviously. During this admission, he had upper GI scopy for his abdominal pain, which showed some esophageal varices type of pictures, suggestive of AV malformations. And he had further imaging of his vessels throughout his body, because overall now this was looking not just like a cardiac problem, but seemed to have vascular involvement at multiple levels. So it was looking like something like a vasculopathy. So I'll pass it back to Dr. Sonal to tell about the radiology.
So because of his severe epigastric pain, we did an abdominal angiogram, which showed that there were multiple dilated and tortuous vessels, especially the common hepatic artery, the hepatic artery proper. You can see the formation of these corkscrew dilated and tortuous vessels. Also, you can see the small arterioles in the intestinal arcade, the jejunal arcade also showed these abnormal comma type of tortuous abnormal vessels. Since there was dilated coronary vessels on the echo, a CT coronary angiogram was done, which also showed abnormal, bizarre dilatation of all the coronary vessels, which were tortuous and abnormal. In fact, the right coronary artery had already formed an intramural hematoma, which suggested that probably there was some dissection, or because of the aneurysmal dilatation, maybe a thrombus had formed. The renal Doppler was done because of very refractory hypertension, which showed that both the kidneys were significantly enlarged. The cortex was abnormally echogenic, but there was no renal artery stenosis, which could explain the hypertension. And the MRI brain with angiography also showed these abnormal, tortuous, dilated, slightly dolichoectatic vessels. And in addition, there was a small aneurysm which was arising from the top of the basilar artery. The MRI brain itself showed these tiny flared hyperintensities in the deep white matter, which was suggestive of probably chronic ischemic lesions from all these lesions in the vessels. So this was, as Dr. Supratim said, truly a multidisciplinary case where cardiology, gastroenterology, nephrology, radiology, interventional radiology, rheumatology, and genetics was involved. And because of this vasculopathy and multi-system involvement, the investigations were done. So I now invite Dr. Archana from the rheumatology team to summarize the findings.
So good evening. Our rheumatology team got the reference basically because now were landing up with a generalized vascular involvement. So we needed to know whether it's vasculitis or vasculopathy. So when we went into details, now here again, apart from multidisciplinary team, again and again, we keep on saying that history and examination are the major leading points that all of us should follow. So again, going back to the history, we found that the child had congenital hydrocele and hernia. He was operated for the same. Phimosis. Whether it was relevant or not is not the matter, but to take history and examination is more important. There was some papers which told us that there was transient hypercortisolism, which led to hypoglycemia, and the child had convulsed twice. Pulmonary stenosis, as Dr. Supratim has already highlighted. Next slide. And then he had a huge file, which we went through. So apart from whatever we've said, and apart from the reports that came up, there were 3 urine reports done which showed proteinuria. Nephrotic range we diagnosed later. Just urine routines were there which showed 2+ or 3+ proteins. So again, what becomes important is not to miss such reports when they come to us. And then we did a protein creat ratio and a PC ratio, which showed us that the range was actually nephrotic. So what do we have now? We have generalized vasculopathy, which has involved the abdominal vessels, and majorly something is involving the kidney, which is leading to this nephrotic range proteinuria. In addition, we found that the inflammatory markers were never high. So here we were not really dealing with a vasculitis, we were dealing with a vasculopathy. And then we went and checked the child from head to toe, and these were our findings. Next slide. So the child on one look did not really look so much dysmorphic, but when you dissected it further, we found that he had large prominent ears, high arched palate, crowding of teeth. When we look at the head and face all together and this crowding out of teeth, do try to see if there was retainment of primary teeth also. This child did not have, but it would have made a difference in our diagnosis later on. His lips were thick, which was not what the parents looked like. dry skin, and there was edema bilaterally, of course, because of proteinuria that was going on. There was peripheral joint hypermobility with skin laxity. And there we thought, Eureka, we have the diagnosis. Maybe it was hypermobility syndromes like Loedes, which can involve the kidney and cause generalized vasculopathy, because of which we sent the gene for this child and we referred to our colleague from the nephrology department, Dr. Nisha, to test the child further, because now kidney biopsy was the only available mode which could have given us, first of all, distinction between vasculitis and vasculopathy, if there was any podocyte involvement because of some genetic problem, or if there was something totally different going on. And so now, before going to genetic, I would like to hand over this to my colleague so that she can tell us about the kidney findings that came up. We can come to this slide later, yeah.
So, hello everyone, this is Nisha. We've done the biopsy for the child primarily because he had the nephrotic range proteinuria, which was up to the tune of about 5 grams protein loss in 24-hour urine, which was significantly high. His renal functions were normal. His C3, C4 profile, etc. are also within normal limits. Urine, other than the proteinuria, did not show any hematuria or any other features. It was largely a bland urine. So therefore, biopsy was made sense because we were not able to arrive at a diagnosis without. But having said that, when we biopsied him, we did see that he had a lot of proliferative changes. The mesangial cells as well as the endothelial cells were showing some proliferations. And the basement membrane also was showing irregular thickening. That could have been probably because of the deposition of C3 and a few other like IgM and in the basement membrane. And his tubules were showing a lot of cytoplasm vacuolations. Now, these are mainly because of excessive proteinuria. There is a lot of zone of injury and hydropic changes, but this is secondary to the proteinuria. Now, just purely by looking at this biopsy picture, the opinion given was that of possibly, may I have the next slide, please? So anyhow, the opinion given for this picture on the biopsy on the basis of microscopy as well as immunofluorescence was that it was a proliferative disease, probably post-infectious because there were some C3 deposits. But it did not make a very clear comment on what it may have been. But when we go and look at the child as a whole, when we look at all of his other features and put it together with the biopsy seems to not really give us an answer of what this disease could have been. So I would like to come back to talking about it if once we discuss the genetics, because otherwise I don't want to speak too much too soon. So maybe if you can go back to the genetics and come back to the last 3 slides. Yeah. Thank you. Archana, if you'd like to just talk about the genetics.
Yeah.
Yes.
So one more thing I would add, even if the kidney biopsy did not give us the diagnosis, it at least told us we are not dealing with inflammatory kidney disease. So we were definitely moving towards something from birth maybe or vasculopathy. So this is the report that we got in a genetic test. Now this gene is an important gene. So here again, I would like to add, first time we did not get this diagnosis. We just got something which is not significant. And that was because this particular gene was a huge deletion from the child's DNA. And the deletion as such doesn't get picked up in the WES, the whole exome sequencing that we generally send. But the genetic labs give us a clue that there's a huge deletion. So you will have to go ahead with the second part of the genetic test, which most of us ignore. So it becomes very important if you have a clinical picture and the physical picture matching, we go ahead and this is what we did. This gene is suggestive of a Noonan disease. Noonan's is a syndromic disease which can it can have all these features, but there is only one case report which we have, which includes glomerulonephritis as a part of this gene mutation. And that is the conclusion that we've reached to. And so I would like you to go ahead, Nisha, now to explain how the kidney has got involved in this gene.
So when we as we've just discussed, the biopsy was not giving us a clear answer other than saying that it is not some sort of vasculitis. But when we go back, given this genetic mutation and a possibility of a Noonan disease and a broader category of the RAS involvement or mutation in the RAS pathway, when we go back to that, we find that there are certain renal anomalies which can be associated with this group of disorders. Largely, may I have the slides on them, please? Largely, they are based on the next one. Yeah, thank you. Largely, they're based on structural anomalies. There may be solitary kidney, there could be hydronephrosis, there could be some duplex collection system or renal cystic disorders. And also commonly seen, when I say commonly, I mean out of the 13, 14 odd cases or how many ever cases, a few of them have been shown to have lupus nephritis. And also the chances of tumors in the kidney are on the higher side. Now, in this RAS group, it is known that there are about 11 genetic mutations that may happen, and each of them will have a different presentation. So therefore, it's impossible to kind of put together as to which kidney anomaly will occur with which of the genetic mutations. But in this child, when we find out that he had the RRAS mutation, they are very rare, and therefore the kidney diseases in them are even rarer. So there have been just 1 or 2 cases, and that too with some structural anomaly. Nephrotic syndrome per se as a presentation hasn't really come up in any of this particular de novo mutation. There have been others which have been because of the lupus that is associated with it. But this particular nephrotic syndrome in combination with the RRAS is an extremely rare and possibly not reported combination. So therefore, as far as the treatment of this is concerned, because we did give him a trial of steroids, I put him on almost 4 to 5 weeks of full dose steroids, but he really didn't respond, and we weren't expecting that he would, because usually these monogenetic causes of nephrotic syndromes are unlikely to respond to immunosuppressive therapies. And so therefore, we obviously had started him, he was already an NVAS, so that itself could act as an anti-proteinuric agent. So as far as the treatment of this alone was concerned, I've also added him on a pioglitazone because it's one of the off-label uses of resistant nephrotic, because there is a lot of controversy and there isn't much literature on the use of drugs like CNIs, that is the calcineurin inhibitors, because this pathway itself deals with cellular mitosis, differentiation, etc. And drugs like CNIs also affect that. So therefore, it's not very clear whether these drugs can be used safely or not. And so therefore, I've chosen a little off-the-track drug to kind of control his proteinuria. And I must say, in the past few months, there has been some reduction, but not total. There is a partial response to that proteinuria. And one other point is probably the edema in the leg may have something to do with the lymphatic dysplasias, which are also expected in these children. So whether it's purely proteinuria or it is associated with some lymphatic issue, that remains to be seen. So back to you, Archana. Thank you.
Yeah, so to summarize, this was an excellent case where all of us had to collaborate, talks for hour and read and do research. Now, one more very important thing was that this gene is a precursor to malignancy. So whatever the child is suffering right now, we are trying to control it. We cannot cure it, but he will have to be monitored continuously for life for development of malignancy, which can come up at a very high frequency. And that underlines the importance of not only going ahead with genetic tests when needed, but also collaborating with all your colleagues, going ahead with academics and research so that we can give a good quality of life, I will say. I cannot say we can cure this. This is monogenic, but yes, we are all trying to give a good quality of life to this child with good monitoring.
Okay, thank you. Thank you, Dr. Archana, Dr. Nisha, Dr. Supratim for joining in and presenting such an interesting case. Apparently, there is only one other case report in literature of this case. So it is only in a multidisciplinary setup with high-end diagnosis, investigations, etc., that we can treat these children, that we can diagnose these children, and we can help them.
Thank you.
Thank you.
So, what's interesting about this patient is that till 10 years of age, apart from the cardiac, there was no other manifestation. And only recently did he start having the proteinuria, the hypertension, and then all these other things fell into place and we got a complete diagnosis. So thank you to all the specialities who helped in the diagnosis and the treatment of this patient.
Thank you. We will now move on to our next case, which was a very interesting oncology case. And I hand it over to Dr. Kriti Hegde from our oncology team.
Sure. Good afternoon, everybody. I'm Kriti. I'm the pediatric oncologist at SRCC, and probably in the next 5 to 10 minutes, I'll take you through this exciting, interesting case, tumultuous history, but happy days currently. Yeah, there. Yes. So this was a 1.5 year little girl who's born of IVF conception. She was a preemie born at 30 weeks. Birth weight was 1.5 kilos with NICU stay of 2 days. She did have all of her newborn screening done and everything was in place. Her history goes back to about 2 months before she presented to us, where she came with increasing loss of appetite. And for this loss of appetite, she did seek a lot of help, where she was given PPIs, given a lot of diets prescribed to her, but eventually she started to she stopped walking. She was unable to sit, stand, and intermittently there was abnormal movement of eyes, and this is what took her to the neurologist. When she did come to us, she had a single caffeole. So neurocutaneous markers are quite important when we do examine children. Because like even in the previous case, or sometimes with mismatch repair, who are predisposed to malignancy, these caffeoles can matter even other than neurofibromatosis. There was no fixing. Pupils were bilaterally equal, reacting to light, and there was no perception of light. So something that started with loss of appetite for 2 months, eventually she came to us completely blind. She was hypertonic, reflexes were preserved, clearly, because the first important thing is, why did she go blind? She had an ophthal evaluation, and following that, there was an MRI done. And I will let Dr. Hiren just describe the MRI.
Yeah, so in such kind of cases where the patient comes with the visual loss, role of MRI is to image the child from orbit to the optic tract, which are coming from the primary visual area in the occipital lobes. So to our surprise, when we imaged the child, there was this large soft tissue signal intensity solid mass lesion, which was located in the supracellular region. And you can see that size of the mass is quite expansive. So at this location, whenever there's mass is there are some 4 or 5 differentials. So it's the role of radiology to tell that which kind of mass it is looking like. It is looking like benign or malignant, and within the vicinity, which is the most likely diagnosis. So MRI with this kind of multiple sequences, we can help the clinicians, oncologists as well as the oncosurgeon to guide the appropriate treatment, that whether the lesion looks like more of a benignish or it is having some sort of high-grade nature. And the other thing we need to highlight that what the lesion is causing to adjacent structures and the location of the lesion. So these all kind of things that can be confidently given by the MRI. You can see that the lesion is predominantly solid. This is the T2-weighted image, which shows that hyper-intense nature. And that is the post-contrast image. The lesion shows intense homogeneous enhancement. And the other images are the diffusion-weighted images and the susceptibility-weighted images. So there were no hemorrhage, and the lesion was showing high ADC value. That means that the lesion was not much cellular. So when the lesion is not much cellular, it will be showing high ADC value. That indicates it's more towards benign nature. So that's the usefulness of the MRI, to differentiate between the high grade and low grade based on that diffusion weighted images. So whenever you have suspected tumor or something, I would like to encourage you, you can directly put in your request slip that please include DWI, especially when you are in peripheral place or tier 2 city where this kind of knowledge might not be there. So you can put that, please include the DWI SWI sequence in your scan so that we can give proper justice to the case. So based on location, the optic chiasma was not seen separately from the lesion, and the location gave rise that this is most likely to be an optic chiasmatic glioma, which is of looking like more of a benign nature considering all the sequences.
Right. So after the MRI, given her visual deterioration in a short span, we wanted to confirm this and we did a VEP. I do have to say that VEPs are not extremely specific, but it is also a good way for us to monitor when we do start treatment. So given this ghastly looking tumor, we called in our neurosurgeon, Dr. Saurabh, who's here with us, and he'll just take you through what he did.
Yes, so I was involved after the radiological diagnosis was made, and yeah, I'm Dr. Saurabh Samantrai. I'm the pediatric neurosurgeon working at SRCC Children's Hospital. So basically, once we had our MDT and we made a plan for going in and first getting histopathology for this tumor to prove and confirm what we saw in radiology. Also, the idea was to cytoreduce or reduce the volume of the tumor because this was also obstructing the pathways of CSF outflow. We did a craniotomy with cytoreduction or debulking of the tumor. Also, as you had seen that the ventricles were enlarged, we had to insert a VP shunt. The histopathology suggested pilocytic astrocytoma. This was in keeping with what the radiology team had suggested already, because optic pathway gliomas generally are pilocytic astrocytomas. So yes, following the histopathology, Dr. Kriti again took over.
So with any brain tumor, the first point would be aggressive surgery. However, when it is pilocytic area and given the eloquent locations, our primary aim would be to get a histopathological diagnosis because chemo does work in such cases. She was started on her first line of chemotherapy, which is vincristine and carboplatin. And given there was a visual deterioration, we brought in steroids to decrease the inflammation and also started her on vision therapy. The plan then was to keep following this up. We do know that these tumors do not completely disappear as they are benign. They don't multiply that quickly. Chemo is not very sensitive, but it is useful in keeping the disease under check. This was her MRI, 9 months in treatment.
So now you can start seeing that the posterior part of the lesion shows some bright looking areas which are more of a fluid or necrotic areas. And overall size of the lesion was slightly reduced. And you can see that even the enhancement, which was very intense and homogeneous in the previous scan, now it is more of a heterogeneous and more marked in the posterior area as compared to the anterior part.
Her VEP had also begun to show some improvement, and what was to note was clinically she was seeing things, she was maneuvering around the house without any help. However, so we would do 54 weeks of this chemotherapy, and at 54 weeks, we tried to give them a drug holiday when we stopped the chemotherapy. And this was her MRI 6 months post-treatment completion, where she came to us. What we started to see was in the temporal field. So given this child is still young, having a subjective way, objective way to measure vision becomes extremely difficult. So we do have to rely on VEP. But also clinically, what we started to see was there was some deficit in the temporal field, which did trigger this MRI, which was in keeping with the progression.
Yeah.
Now, with this second line, we did start second line. However, she was not making a lot of clinical improvement. This was just one agent that we call vinblastine, which is weekly chemotherapy. Despite being on vinblastine for about 6 months, she continued to be symptomatic on and off with visual complaints. Finally, we brought in a drug called bevacizumab, which is nothing but an anti-VEGF. So it cuts off the vascular supply of these tumors. There is bevacizumab is used quite often in adult tumors, but not as much in children. However, there is a lot of emerging data and not a lot of centers do use this drug, but here we were able to use this drug for this child. I'd like Dr. Hiren to comment on the MRI, and this was just after 5 cycles of this drug.
Yeah, so what we are trying to say that follow-up MRI is very important for the tumor progression or regression. And I would like to highlight one more point that if given a chance or given a choice, you should do the imaging at the same center or same hospital where the MRI was done first, because the way the contrast is being given and the way the MRI sequence is run on each system is different. So if you want to do follow-up of the patient, like if you're expecting 3-4 follow-ups of that same patient, you should do the imaging at the same center or hospital. So coming to this case, that we can see that the left side of the image shows the current image and the right one is showing the previous scan. So if you see craniocondylar, there is reduction in the bulk of the tumor as compared to previous scan. And again, you are seeing more cystic or necrotic looking area, which is indicative of treatment response, which shows that further necrosis of the tumor. And even if you see that these are the midbrain area, and initially the tumor was causing much more splaying of the midbrain part, which has slightly reduced in the present scan, and overall bulk of the lesion was also reduced.
Right. So I think there are 2 ways of looking at this, right? If you were to see the images, you would tell that this probably, there is still a huge tumor. But I think what we go by always is clinically. And this is the child currently with somebody who had come to us at 18 months of age where she was blind. And this is her currently. Right. So I think videos, pictures speak 1,000 words. There is a lot of nihilistic attitude when it comes to pediatric tumors. But I think what is important is that these tumors get discussed in a multidisciplinary team, and we are not just going by the size of the image and things like that. It is a lot of brains that goes together and trying to give them a really good quality of life. And for that, I do have to thank our multidisciplinary team at SRCC. We look at children with brain tumors and other solid tumors with a keen eye every Wednesday, and this is our team. So I have to acknowledge Department of Radiology, Pathology, the pediatricians, neurologists, our neurosurgeon, and the oncology team, along with rehabilitation, which is why we are able to give them good outcomes who are otherwise deemed not treatable and are sent home. And there is a saying in oncology that it takes a village to treat a child with cancer. So it is important that we work in a team. Thank you.
So yeah, thank you, Dr. Kriti, for that wonderful discussion on the pediatric brain tumor, which was located in the suppressor location, causing vision loss, and how we dealt with it. Now we'll further invite a case from cardiology department, Dr. Priya Pradhan, who is a full-time consultant pediatric cardiologist at our hospital. She would like to show one case, and Dr. Sonal will tell about the radiology finding and subsequently the management.
So this was a mother, 32-year-old. She had a twin gestation after 12 years of taking infertility treatment. This was an IVF pregnancy. So she came for a routine anomaly scan, which we did at 18 weeks and again at 20 weeks. Sometimes with twins, we need to repeat the anomaly because they usually are a little smaller than the normal babies. And we did a fetal echocardiography again at 24 weeks, where we saw a pulmonary atresia with a ductus-dependent pulmonary circulation. So these were our antenatal imaging findings. So when we image twins, we always divide them into fetus A and fetus B. The fetus which is closer to the cervix is labeled as A, and the one that is away is labeled as B. So this was fetus A. And here you can see that there was only one ventricular outflow tract seen, which was originating from the left ventricle. There was no obvious pulmonary artery. So we suspected that there was pulmonary atresia. Single outflow tract, which was most likely the aorta, which was arising from the left ventricle. And this was confirmed by the echo images, which showed the same findings. In addition, there was a small VSD seen. We can see the crossing over of the flow between the two ventricles, and there was a ductus arteriosus. So because of the finding of pulmonary atresia in a twin pregnancy, which is already complicated and high-risk pregnancy, we referred this baby to our pediatric cardiology department, and Dr. Priya will explain to us what happened after that.
Before we go to this particular case, hello everybody, good afternoon. I'm Dr. Priya Pradhan. I'm a senior consultant pediatric cardiologist working in SRCC Children's Hospital. And as you saw that Sonal referred this fetal echo. So we have a fetal clinic wherein we have multidisciplinary people working with the same. See, when a baby is formed abnormally, there's not only one system is involved. There are always many systems can be involved, and hence we always need to have a lookout for these abnormalities and involve those kind of specialists in the system. So why fetal echo diagnosis is important? We all know that there are not many fetal therapies that are available. So once we know that there's a problem, is there anything that we can do about it when the baby is in the womb? So unfortunately, the answer is not a big yes. Some defects have some little bit of treatments available. Fetal interventions per se in India are not very commonly done, but certain medicines can be given to the mother for certain kind of defects like arrhythmias in the baby, which are quite useful and that really help in a big way. So why do we actually need to do fetal echo, and why really we need to create awareness about these fetal echoes is what I need to highlight on and take 2 minutes of everybody's time. First is it predicts critical lesions. So even termination can be planned. See, there are certain lesions which are incompatible with life or may have poor quality of life for the child. So better that we can talk to the family about this and we can plan, if required, we can plan a termination. Secondly, if this child is a treatable child, then where to deliver, when to deliver, and how to deliver. All these answers can be, the questions can be answered if a good fetal echo is done. Because even if a lesion is diagnosed, not all lesions need to actually get delivered in a tertiary care center. Sometimes a defect like a VSD just needs a routine echocardiogram in a consultant's routine OPD when the baby is born and is stable. But certain kind of lesions, which are called duct-dependent lesions, in which the PDA is the source of either the systemic or pulmonary blood flow. If the PDA closes, then the baby's life is life-threatening. And hence, these kind of children need to be born in a place where prostaglandin is available. Certain kind of ventilatory facilities are available. So these answers can be given if a good fetal diagnosis has been made. And we can reduce the hemodynamic collapse at birth. Again, neonatal outcomes are very good if a baby has been born in an environment and treated immediately. See, if we treat, even if the heart is treated, but because of prolonged hypoxia, the brain has suffered or any other organs have suffered, then it will lead to quite a long-term morbidity for this child. So we need to, if you have to have best neonatal outcomes, a fetal diagnosis is very essential. And of course, then parents can get realistic expectations. We can prepare them mentally, financially. So once a prenatal diagnosis is made, we can plan the delivery, we can plan early stabilization. And in this child, we plan that the baby has to be delivered in a hospital because we need to start prostaglandin at birth because it's a duct-dependent lesion. See, pulmonary artery supplies blood to the lungs. It comes from the heart. This child does not have a pulmonary artery. So how is the blood going to the lungs? It's going to go through the PDA, that is
patent ductus arteriosus, which is a pipe which connects the aorta to the pulmonary artery. Now, usually this PDA starts closing after 48 hours of life. So now if we had not known that this baby is suffering from this disease, after 48 hours, this baby might have crashed, hemodynamic collapse would have occurred, and then we might have lost the baby. Already the baby was the smaller one amongst the twins. And hence, because we knew that this baby has this problem, we could deliver them in our center. We started prostaglandin at birth, and then we had time to do the echo and then plan the procedure. So we did a PDA stenting at birth. So these are the PDA fluoroscopy pictures. Yeah. So this was day 3 of life, birth weight was 1.2 kg and PDA stenting was done. So what is PDA stenting is basically, see, in the first diagram, we have put a catheter from the carotid artery and it has gone into the, it's a carotid artery is a branch of the aorta. So dye is now going into the aorta, and if you can see, there's this vertical pipe which connecting to the aorta to the pulmonary artery and the branch pulmonary arteries which are supplying the blood to the lung. Now we need this pipe to remain open, and hence we placed a stent. The uniqueness of this procedure in our hospital is that we have now developed a very good program for PDA stenting. This is traditionally a very high risk procedure, and if you see the birth weight and the weight of the child is 1.2 kilograms. So again here, not only radiologists, but we need like a very good team, anesthesia and intensive care for this procedure to actually succeed. So when we put a stent here, we have used the surgeons to do a carotid cut down for us. And then that's how we have got the access. And when they stitch the carotid, then the vascular complications are less. So this other completely different part, but this is a very intense kind of a very high difficulty procedure, which was very successful in this child. And this child went home very with saturations of around 65 to 80%. Just so this was the CT angiography that we before that. So after at birth when the child went home, now what we need to do is we need to fix this problem permanently. So how do we do it? We need to do a surgery. So we need to connect a connection from the right ventricle to the pulmonary artery for permanent solution. Now, when we do that can we do that at this point in time at 1.2 kgs and at birth? The answer is no, because the complication rate is very high. So we made the child grow. Because of the PDA stent, the stabilization occurred. There was a permanent good amount of pulmonary blood flow which was established for this child. And this child grew to 8 months. Now we have to plan a permanent solution for this child. So now before planning the solution, we did an echocardiography, but we did not get all the answers through an echocardiography to plan a surgery. So what are we required to actually plan a surgery? We need to know how big are the pulmonary arteries? Have they grown well? How is the arborization? So is the lungs supplied well? How is the part of the stent? Is it compressed anywhere? And many other things like MAPCA. So there are various aortopulmonary collaterals which need to be closed if they are present before the surgery takes place. So a lot of anatomy which is not seen in a routine echocardiogram is seen by the CT. So we had to get a CT done, and we send this patient to the radiologist to help us plan surgery, even the timing of surgery and the feasibility of surgery.
So the CT angiography, which we again do with the help of our cardiac anesthetists to make sure that the baby is deep asleep and doesn't move. So that was done before intracardiac repair. And we found that the PDA stent was absolutely patent as the branch pulmonary arteries were filling well. Also, both branch pulmonary arteries had grown adequately and they were showing good caliber. There were no significant MAPCAs. And on the basis of this, the cardiac surgery was planned. So, yeah, everything went on well, and this is how the child looks. So if you can see the pictures at the first time when the baby underwent the PDA stenting, then the second was the interval. So here the baby was doing well. This baby is at 3 months of age, and now just recently in Navratri times, she sent a picture to me, the mother, and they're so happy. So what we could do is we actually could establish the right pulmonary outflow tract by just pulling out the pulmonary artery and joining it to the heart. So we did not need an extra pipe
which is called a conduit, and that now saves further surgeries. So if we needed a conduit, then we would have to have 4 surgeries for this child in future, predictable at least, because this pipe falls short or doesn't stay that long, and the repeated change of the pipe is required. So this happened just because of all the radiology and the multidisciplinary backup that we had, and so that we could choose a perfect time for surgery, which was neither too late nor too early, and a perfect time where we knew that through the CT findings that we can actually pull this, there's enough place for us to pull the main pulmonary artery to the right ventricle. So I would just say that this is like a relay race, we are carrying the baton is the child. So we have to really carry it in the most efficient way and put it across to the next consultant, and then they have to carry it forward. This is what helps the best outcome for any child to have when such a interdisciplinary coordination is there.
Thank you. This also, we would like to acknowledge our neonatology, our NICU and our SICU teams who helped greatly in making this child reach where she is. And with that, we now move on to our next multidisciplinary case, and I call upon Dr. Tanvi and Dr. Indu Khosla from our pulmonology team, who will also show us a very interesting multidisciplinary case. You can see there's marvelous work.
Good afternoon, everyone. I'm Dr. Tanvi Modi, second year fellow of pediatric pulmonology at Narayana Health SRCC Children's Hospital. And I am guided by Dr. Indu Khosla, who is the head of department, pediatric pulmonology, allergy, and sleep medicine at our hospital. I would like to present a very interesting case of a 1.5-month-old female child, 4th by birth order, born full term, normal delivery with a birth weight of 2.4 kg. She presented with fast breathing since 10 days, poor feeding and failure to thrive. She was hospitalized, intubated, ventilated for 1 day, stabilized, and then extubated and referred to our side. The evaluation done before she was sent to us was a 2D echo, CT chest, and a flexible bronchoscopy before transferring to our center. When she presented to us, she was lethargic, had shallow breathing, was tachycardic, respiratory rate was around 30, saturation, she was auto-dependent, she would maintain 96% on 1 liter of oxygen by nasal bronchs. Her perfusion was good, her pulses were well felt. On auscultation, there was a pansystolic murmur heard, and on respiratory system examination, there was decreased air entry on the left side. Her ABG on presentation had a pH of 7.42, CO2 was 56, and oxygenation was 124. This was her X-ray on presentation. I pass over to Dr. Hiren to explain the X-ray.
Yeah, so if you have attended the basics of the pediatric chest radiograph, now you can apply the same rules, starting from the central to periphery. And what you can see here that the heart shadow, it is pushed towards the right side, and the left lung, especially the upper and mid zone, they are looking like abnormally hyperinflated. And you can see that, see carefully that there is some sort of transmediastinal adhesion of the left lung through the mediastinum towards the opposite side. And that is the left lower zone, which is showing some sort of compressive atelectasis of the left lower zone area. If given this kind of X-ray, then I would like to ask the pediatrician that is there any previous radiograph available or not, especially at the birth or neonatal time, to compare that these findings were persistent at that time or is it a new finding. So the initial impression from this is like some sort of hyperinflated left-sided upper lung, predominantly the upper and mid zone, which could be congenital in origin or which could be obstructive in origin. Considering that the child was having some sort of history from the birth, it looks like more of a congenital in origin.
With this kind of presentation, the child was admitted to the pediatric intensive care unit, kept on non-invasive ventilation. The 2D echo done had dextrocardia, leftward malalignment of the septum primum, leading to restriction of the mitral valve inflow. Pulmonary veins were draining normally to the left atria, but the flow was preferentially to the right atrium due to the TFAVD physiology. Large OSASD with left to right shunt, a small mid-muscular VSD with a left to right shunt, moderate PAH, and a dilated RA and RV. A flexible bronchoscopy was done, which showed laryngomalacia, and there was some external compression of the right bronchus intermedius with a small right lung. The CTPA was then done to have a better look.
Yeah. So the role of CTPA here is just to look for the whatever echo findings were there and to look for that anomalous course of the pulmonary veins. So here you can see at this location, this is the right atrium, and the left atrium. You can see that a normal septum is showing a wide defect, which is the septum secundum kind of ASD. And you can see these are the pulmonary veins. So the advantage of doing CT scan is that sometimes echo, they may not clearly demonstrate the anomalous course of the pulmonary veins, which chamber they are going directly or via some chamber and then it's going into the atrial cavity. So this kind of anatomical orientation is better depicted on the CT scan. The other thing that CT...
Yeah, I would just like to add that our surgeon needs to see the CT also because the individual vein size is very important, and second is the size of the common chamber. So for surgical anastomosis, they have to connect the common chamber to the left atrium. And that is where it is very crucial that the size of the common chamber is good, and it is best seen, all these pulmonary veins and the extracardiac structures are best seen on CT scan than on the echo.
And CT has this thing, advantage of doing 3D VR images so that we can see the individual pulmonary veins as well as rest of the part of the cardiac and extracardiac structures in 3D way, which is also very useful for the surgeons, which way to go, right thoracotomy, left thoracotomy, which route to go, and it's very useful by this 3D VR. The other advantage is that by doing only one CT scan, we can see the lung parenchyma as well as we can evaluate the cardiac structure. So we don't have to do two separate studies. That is the advantage of doing CTPS. Since we also include lung fields while doing CTPS. So here, what we can see that what we saw on the radiograph that the left lung was hyperinflated, which is seen on the CT scan also. That left lung is more loosened as compared to the right lung. And if you see the vessels, they are having more distance or they are attenuated and sparsely seen in the periphery. And the lung is more loosened. And here we can see that there's some mediastinal shift towards the opposite side. So when you see this kind of hyperinflation, it could be congenital in origin, that what we label it as a congenital lobar overinflation. Or sometimes it can happen secondary to obstructive lesion in the bronchus supplying that area. So it's very important to assess the airway in those kind of cases, and especially when the child is having cardiac anomalies, they are prone or more likely to be associated with the external compression on the airway. So this all information CT can give you. And in this case, you can see that the left main bronchus is patent, and there is no external compression by any anomalous or normal pulmonary vessels. So this was lung parenchymal anomaly, which is known as CLO, which is congenital lobar overinflation, and there was no obstructive cause or any mediastinal lesion causing it. So based on this finding, here these are a few more cuts of the same finding. These are the coronal view, just show you the hyperinflation and expansion of the left upper lobe. And this is the compressed left lower lobe. Yeah, I'll hand over to Dr. what happens subsequently after the CT.
With that expert radiology, the anatomy delineated so clearly in the CT and the CTPA. Now there was a multidisciplinary team involved. Based on the radiologist opinion, the cardiology, CVTS surgeon, PICU team, pediatric surgeon, and our team of pulmonology were involved. The multidisciplinary meeting was held, and after discussion, it was decided to deal with the CLO before touching the complex cardiac defect. The surgery that was undertaken was a left posterior lateral thoracotomy and a left upper lobectomy under GA with endotracheal intubation, because this was causing a significant mediastinal shift and ventilation would have been poor. After stabilizing with the lobectomy, that was when the TAPVC would be dealt with. This is what was seen, that the left upper lobe, which was resected, was found to be emphysematous. The lower lobe was completely collapsed. Pulmonary artery and vein to the upper lobe were isolated and ligated. The upper lobe bronchus was transfixed. Lobectomy was done and the ICD was placed. There was no air leak after the surgery. Histopathology sent showed lung parenchyma with the over distension of the alveolar spaces, and all the findings were consistent with the diagnosis of congenital lobar overinflation. Post-operative status: the child was extubated in 24 hours, required NIV support but was gradually weaned off oxygen support. ICD was removed in 2 days, and he was maintaining saturation on room air, had no distress, and was eventually discharged. A repeat echo done showed pulmonary arterial hypertension. The child was put on furosemide and planned for cardiac surgery after 4 to 6 weeks or earlier in case of any clinical deterioration. After discharge, the child's follow-up 2D echo showed a worsening of the PAH and was advised to do surgery. However, in the interim, while the surgery could be planned, within 3 days, the child followed up with another high-grade fever, cough, cold, required PICU, HFNC, and IV antibiotics. I request Dr. Hiren sir to comment on the X-ray again.
Now we can see that there are some sort of asymmetrical airspace opacity, which are more of a perihilar and pericardiac distribution. They are more on the left side, more on the right side than the left side. And we can see this kind of air sign. That means that there is some amount of collapse consolidation happening in those regions. Considering the distribution of the areas in pericardiac, perihilar location, it could be some sort of fluid overload or pulmonary edema developing in that child. That should be our initial impression.
This child was treated in the PICU with HFNC, IV antibiotics, and gradually the oxygen support was tapered, the infection was controlled, and once all the infection resolved, was taken up for a TAPVC and ASD repair and a cardiopulmonary bypass. It was the misaligned intra-atrial septum was excised, ASD closed with a pericardial patch. The child tolerated the procedure well and recovered. Child was discharged on NVAS, aspirin and furosemide. Now the child is on regular follow-up. The repeat echocardiography shows an unobstructed pulmonary venous drainage in the left atrium, no residual ASD and no PAH. Currently, all the medications have been tapered and stopped and has had no complaints or respiratory distress, hospitalization since this procedure. Child is gaining weight, developmentally normal, and now feeding well. So our take-home message after this is the multidisciplinary collaboration, the timely diagnosis, systematic stepwise management can prevent complications and improve the outcomes. And a big thank you to everyone involved in diagnosing and treating this, Dr. Hiren sir, Sonal ma'am, my guide Dr. Hiren ma'am, Dr. Abhinaya, Dr. Rasiksha sir who operated, Dr. Pradeep Kaushik sir, Dr. Kshitij sir, and Dr. Lopa ma'am who's a cardiac anesthetist. It's the teamwork makes the dream work, and thank you so much.
Yeah. Thank you, Dr. Tanvi. That was really a very interesting case, which was involving the pediatric pulmonology, cardiology, cardiac surgery, and of course the radiology. Now I would like to invite a case from neurology. Dr. Rag Deepika is there with us. She is DNB resident, and we are privileged that we have got a huge pediatric neuro department with very complex amount of work we are doing at our hospital in pediatric neurology. We are also doing epilepsy surgery, which is a kind of state-of-the-art work. And without wasting much time, I would like to invite Dr. Rakdipika to take over and show the case.
Good evening, everyone. So today, now we are going to present an interesting multidisciplinary case which involved neurology, hemato-oncology, infectious diseases, radiology, and neurosurgery. And here we're presenting you 9-year, 5 months old girl. She is a known case of beta thalassemia major. She was transfusion dependent. She was given blood transplant was done in May 2025. And post-transplant from May to July, it was roughly around 2 to 3 months, and she developed a series of infections involving mucositis, diarrhea, and oral candidiasis, and CMV infection, adenoviral infection, severe pancreatitis, after which she has developed onset of fever for 1 to 2 months. And when in September, respiratory biopsy was showing COVID and RSV positive, and symptomatic treatment was given. However, the point to note is in this 2 to 3 months, she was actually looking at with her local practitioners for all these infections. And when she was in the month of September, she was immunocompetent status with a absolute neutrophil count was 6,000 cells, and she had developed tremulousness noticed while standing and walking for 1 day, which was roughly 4.5 months post-transplant. On examination, head circumference was 45.5 centimeters, which was microcephaly with short stature and thin body habitus. She was active and alert. However, the speech was comprehensible, but few words. She was speaking very fast out of the normal flow. In stance, there was no swaying, but gait, mild broad-based gait was noticed with mild facial asymmetry, blunting of left nasolabial fold, which was left 7th human facial palsy. Power was normal and brisk reflexes on both sides with plantars were bilateral flexors. And in view of acute onset focal deficits, which was localizing to pons and cerebellum, we have done an MRI, brain, and spine. So in the MRI, we found that there were multiple abnormal signal intensity focal lesions seen scattered throughout the supratentorial and the infratentorial brain parenchyma. They showed surrounding perilesional edema, and they all showed a typical ring enhancement on the post-contrast study. There were also multiple lesions in the spinal cord. On screening the spine, we saw multiple lesions in the spinal cord with very severe edema, which was extending in the entire dorsolumbar region. And so on the basis of these multiple ring-enhancing lesions, they were all at the corticomedullary or the gray-white matter junctions. They were in the corpus callosum, basal ganglia, within the brainstem. We considered the differential for ring-enhancing lesions in this child with the background of having undergone a bone marrow transplant as tuberculous meningitis, because the lesions were there in both the brain and the spinal cord. Then fungal, because they are very common in these patients. Even if they are immunocompetent, they tend to have fungal infections, and especially in this case, there was tiny focal areas of hemorrhage along the walls of the lesion with ring enhancement. So that was the second strong contender. Toxoplasmosis also is always a consideration when you see a basal ganglia lesion, but it's unlikely when you see spinal cord lesions, and also toxoplasmosis is seen when the child is very severely immunocompromised with a very low CD4 count, typically less than 150. So that was little lower down on our cards. Neurocysticercosis is a radiological differential, but we did not consider that in this child. Demyelination is another differential for a ring-enhancing lesion, but again, not applicable in this child. And listeriosis, which typically tends to have microabscesses, but again, less likely to be so disseminated in supratentorial, infratentorial, and spinal cord regions. So we have empirically started her on antibiotics, meropenem, colistin, and with antifungal coverage with liposomal amphotericin B and antitubercular therapy. And then we have done a CSF analysis.
Cells were 25, which were 80% lymphocytic predominance, and protein was elevated 148, and sugar was roughly normal with RBS, simultaneous RBS was 92, and CSF gene expert, toxo PCR, Cryptococcus, bacterial meningitic panel, and fungal panel came negative. So now we have actually involved a neurosurgery team. So for the brain biopsy, so we have taken brain biopsy from the lesion on the right frontal region. Aspergillus PCR has come positive. Here we want to give the message was because of the multidisciplinary involvement, like hemato-oncology person and infectious diseases expertise, and also neurosurgeon, neurology, all have, including the radiology. So we could actually derive at a diagnosis with aspergillosis in this child. However, the picture is different after this. And she had shown clinical recovery of speech and gait in a period of 4 to 5 weeks, after which she had developed new complaints after an episode of gastroenteritis. She had gained tremulousness while walking for 2 days, and on examination, there were cerebellar signs with power was 4/5 in all limbs with wrist DTRs. So we have done a repeat MRI.
So in the repeat MRI, we saw that there was a significant improvement of almost all her lesions, except for the lesions in the brainstem. There was a new lesion in the midbrain, which was spreading inferiorly to involve the pons and the superior cerebellar peduncle. So it was a little bit of a conundrum because on the one hand, most of her supratentorial lesions were improving significantly, but there was a new lesion in the brainstem and worsening of the prior lesions that we were seeing in the brainstem. But again, only brainstem. Even the spinal cord lesions have significantly improved.
So we were actually in the doubt that whether this is the previous disease which is actually progressing, or whether we should consider this as an iris, which is immune reconstitution inflammatory syndrome. So both of which actually, for the coverage of steroids, we have started her on dexamethasone. However, clinical deterioration has been noted over a period of 7 to 10 days. So there was drop in GCS, there were new focal deficits like right-sided hemiparesis and right lower limb was dystonic, and progressive ataxia has been noted. And then she was intubated and we have repeated an MRI brain.
So the repeat MRI brain now again showed very severe worsening of her previous lesions, which had improved. And in addition, multiple areas of new lesions had come up in the left insula, in the brainstem, going down into the medulla. Even the spinal cord lesion, although the edema had reduced, but the lesion in the conus medullaris was showing more enhancement. So this was definitely a worsening pathology. The lesions were worsening and new lesions were coming up. So somewhere she was either resistant to this infection or she was growing multiple pathogens. We were a little bit at sea now.
So we have repeated a CSF analysis, and CSF are showing 18 cells with a 80% lymphocytic predominance, and protein is elevated, which was 126, and sugars was normal, and AFP stain and gene expert came negative. Pyrosequencing for the TB and it came negative, and fungal, bacterial, viral, and parvovirus came negative. Currently, we have started her on voriconazole, thinking of resistance to the liposomal amphotericin B. In view of aspergillosis, we are still considering that, and we are actually looking for the response in this child.
So thus far, we showed you happy endings for all the patients, but we don't always have happy endings in spite of involving multidisciplinary teams like this case where we are really at sea, and we may consider repeating a brain biopsy. But many thanks to all our specialists who joined in today to show you this plethora of interesting cases, some successful, some not so successful. And it is only in such a setup with a multidisciplinary team that we can actually look after such complex cases. And I would like to now close the CME with one last talk as to why we celebrated this CME with an International Radiology Day celebration. And the theme of the Radiology Day for 2025 was to honor the radiographers who help with seeing the unseen. As you can see in all the cases that we showed today, a lot of it, the diagnosis would not have been possible without our radiological inputs. Okay, so International Radiology Day is celebrated every year on November 8th. And it commemorates the day on which X-rays was discovered. That is on 8th November 1895 by a German physicist called Wilhelm Conrad Röntgen. And this day highlights the role of imaging in modern healthcare, and it honors those professionals who help in making an accurate diagnosis so that the child or the patient can get accurate treatment. And the backbone of our imaging and the backbone of our radiology practice are all our radiographers, who are the first point of contact in radiology. They are the ones who ensure patient comfort, safety, and positioning, and they operate complex imaging equipment with great precision. Radiology today actually helps to see the unseen, because radiographers translate invisible signals into diagnostic images, which helps to detect diseases early and helps guide life-saving interventions. There is absolutely, as we all know, a huge role of radiology in emergencies for trauma imaging, stroke pathways, and for rapid decision support for clinicians, whether to intervene or not and how to intervene. So this is a case of stroke. It has, of course, had a great impact on healthcare in the form of early diagnosis, reducing morbidity and faster treatment planning. And in fact, radiology has gone a step forward into interventional radiology, where minimal access vascular work is done without actually cutting down any part. And I would like to highlight two cases in which radiology played a very important role for timely diagnosis, management, and treatment. And this was a 3-month-old baby who presented with increased crying and irritability since 2 days following vaccination. So the crying and irritability was attributed to that. But then on day 3, he developed an acute urinary retention and he was not being able to pass urine. And an ultrasound was done, which showed that the bladder was over-distended and there was a mild fullness of the pelvic-ileal system on both sides. And the pelvis actually showed a large soft tissue mass, which was engulfing the prostate gland. And this child underwent an MRI, a staging scan, and a biopsy, an ultrasound-guided biopsy on the same day. And within 3 days, he had a diagnosis of embryonal rhabdomyosarcoma. On the day after that, he got a port inserted, and he has already started his chemotherapy in under 5 weeks. So radiology helped in the timely diagnosis. Again, this is a 10-year-old boy from a very good socioeconomic background, was delivered in a very high-end center, went to the best pediatricians, had all his well baby care visits. He was absolutely well so far. And he came with pain in the right iliac fossa, which was suspected to be appendicitis. And he underwent CT scan of the abdomen. But while doing the CT scan of the abdomen, we found a soft tissue lesion in both the iliac fossas. And on further probing and examination, it was found that he had bilateral undescended testes, which had been missed so far in a 10-year-old boy. And it is only because we did this CT scan for a completely unrelated reason that we were able to pick this up, and the child was able to have an ochiopexy, and hopefully his testes have now survived and grown. So, of course, radiology plays a great role in diagnosis and management decisions. But as we all know, we are shrouded with the one negative aspect, which is radiation. And of course, radiation is not good for anybody, but we have to weigh the pros against the cons. That is why in a pediatric center, we tend to use more of ultrasound and MRI, which does not have ionizing radiation. And these are the approximate doses of radiation that one gets when you undergo all these investigations. And the maximum annual permissible limit for radiation is for any child is only 1 to 2 millisieverts in a year. So any CT scan you do crosses that limit for sure, but you have to weigh the pros against the cons. So please advise investigations responsibly and reliably. Now, we do get a lot of children who do come for CT scans, and the first thing we see is whether the test advised is appropriate. If we find it is not appropriate, we always talk to the referring physician and try to convert that into an ultrasound or MRI when applicable. We use all the possible radiation protection devices. We carry out the necessary radiological procedure using the ALARA principle, which is as low as reasonably achievable. And our technicians take great efforts in maintaining all the equipment and quality control so that there is not too much scattered radiation or too much background radiation that is being imposed upon the patient undergoing the test. Now, we know that radiology was, X-rays were invented in 1895, and now it has been almost 130 years, and it has come a long, long way. And radiologists the world over have truly combined skill, compassion, and commitment to technology to try to develop more and more non-invasive methods of imaging patients and getting the diagnosis, which truly has benefited medical science and has truly helped in making management decisions and guiding further treatment. So radiologists have been committed to accuracy, and we all know that they are essential to every specialty and subspecialty of medical science. Requires radiology and medical imaging to reach the correct diagnosis in many, many cases where the clinical evidence does not support the findings. And so this is just to show you that radiology definitely helps seeing the unseen. And we thank you all for joining us today for this radiology-based masterclass. Thank you.